We're live? Very good. Welcome everyone to our ICB's public board meeting. I'm going to kick off by doing a few welcomes, the odd goodbye, and a few congratulations, if that's all right, before I get into the usual sort of apologies for the meeting and that kind of thing. So I want to welcome our new interim cluster chief executive, Mark. Welcome to you.
Thank you, John.
Is there anything you'd like to say at this point, or happy to?
No,
happy to go.
I'm
I'm going to say a few things. I am delighted that you're here. Right? I think it's really important that after what is now effectively nearly 7 months of the cluster starting up, that I think the two teams have done a fantastic job getting to this point. I think now under your leadership. That's the 10 o'clock test that's slightly late, all right, so I hope anyway. So I think under your leadership, we've got a great future to look forward to with our committed teams. We're aligning our two teams from the 1st of April. And I just wanted to say congratulations up front to all of those who have been appointed. And obviously there are some colleagues who are not going on the journey with us. I wanted to just reach out to each of them and say thank you for everything you've done with us since we started the cluster. And we'll be talking to you with arrangements as we go forward. So welcome, Mark. On the back of that, of course, we've actually had two acting chief executives, one for Cornwall and one for Devon over the last few months. Susan, I know, is on the screen. Thank you ever so much, Susan. You've done an absolute first-rate job. I wanted to call that out in public. Thank you ever so much for everything you've done there. And Libby, where's Libby? Libby, on behalf of the board, as you were acting up chief executive for Devon, you too have done a tremendous job. Thank you ever so much for everything you've done, and to your teams. And can you pass on to the two of you our thanks for those who acted up while you were acting up, as it were? They were absolutely pivotal to keeping the show on the road. So thank you for that. A couple of goodbyes. I'm going to start with Salma, who's on the screen. Salma, hi. Salma is one of our non-execs will be leaving this. This is your last board meeting. And that Salma was one of those colleagues who came as a non-exec from Devon. And I have to say, it's going to be a huge loss to us. The insights that you've brought, Salma, your clinical background, your professional approach to everything, your calmness. I have a lot to learn from your calmness, Salma. I shall miss you massively on that. And at a personal level, I wanted to say thank you from me personally to you for everything that you've done and all your support. And Steve, this is your last board meeting. Now, I've known you since you first started down here, and you've been absolutely instrumental in leading Royal Cornwall Hospital to the phenomenal success story it is today in terms of its national position. So I'm going to say I think Morecambe's gain is our loss on that. So thank you for everything you've done for us as well. Good luck to you and your family. All right. So let's move on. I don't think I've missed anybody. If I did, I apologise. It was my best of intent to do the right thing on that. We've got a number of apologies, people on holiday or away from us today. I think we just capture those as we are. We have some colleagues who are joining us online, which is absolutely fine today, I understand, so your personal circumstances. And later on, we have some other colleagues joining us to help particular papers. Now we have some members of the public, and we'll get to the public questions in a second, if I may. I'm going to move on to declarations of interest.
Yeah, John, I just need to raise. Obviously, I am a non-executive director at Birmingham, Black Country, and Solihull ICB.
Yep.
I will make sure that declaration is recorded as part of my. As part of my onboarding in the ICB. We've discussed that, we've discussed it with the centre, and we've discussed it with Birmingham ICB, and it's seen there is no conflict because there is no real association between the two ICBs and the geography.
Yeah, if you can add that, and that's noted. Thank you very much for that.
Yes, and I can confirm that has been included on our register of interest. Unfortunately, papers were presented before we got that updated, but it is there now.
Okay, thank you very much, Mark. Okay. All right. Minutes from the previous meeting. Happy for it to be recorded as an accurate reflection. Looking around the table, everyone. Yep, lovely. We'll take that as done. If I can turn to Philippa on the action log, please.
I think 2 comments on the action log. One is that we have managed to close a number of actions down this month, and the ones that are in progress tend to be in relation to a board development programme that needs to be pulled together with which is due by the May board meeting. So I don't feel that we need to go into those in any detail. I think there's one. There are 2 actions that I'd like to ask people to give updates on. Unfortunately, one of them isn't able to be with us today. That's Penny Smith, so we'll just leave that as an action that still requires an update. But I would go to Lincoln Sargent on action SWPB 25025E. Sorry, I just zoomed in far too far. Just to provide, and I've given Lincoln a bit of an update before.
Yes, thanks. So I've been in touch with Susan now that she is in post as the executive lead for mental health and suicide prevention. We've shared the Devon 1 suicide plan, and we will then, once she's settled, begin taking forward how we work together. Libby has been in conversation with us, and certainly from a kind of public health, local authority point of view, we're already having conversations. Thanks.
Thank you. So on the basis of that update, I'd recommend that the board agrees to close that action.
Everybody happy with that? Very good. Well done, Lincoln. Thank you very much. Anything else? Okay, can we move to public questions, please?
Yes. So we've had a number of questions come in which have not related to items on the agenda. So I just wanted to confirm that those questions will be dealt with outside of the board meeting, and the teams are in the process of responding to those. We've had a number of questions in relating to our dementia strategy, and so I would like to go to Phil Mante just for those.
Thanks, Philippa. So I'm really happy to say the board's going to be considering the Devon dementia strategy under item 3.3 today. So I'd like to pick up any queries at that point during that discussion.
Yes, very happy with that. Anything else?
Yes, apologies.
Yep, don't worry.
Switching between many tabs. Then the other questions related to postural tachycardial syndrome, otherwise known as POTS, and I will pass that on to Libby Ryan-Davis.
Thank you, Chair. So we've received a large number of similar questions on this topic of POTS. Although it's not on the agenda today, just want to provide a brief summary of our commissioning position on this. And as Philippa said, we will reply to each individual question in the coming days. So POTS is a condition where part of the nervous system that automatically controls things like heart rate and blood pressure isn't working properly. Despite a significant review and a number of attempts to commission a Devon-wide service for POTS, it's not been possible to identify local teams with the appropriate breadth of experience required to effectively support this group of patients in our population. In discussion with our partners, it was clear that there is no clinician currently within the wider Devon system to do this. So during this extensive piece of work, the local NHS found that individuals are presenting with symptoms associated with conditions such as POTS, hypermobile Ehlers-Danlos syndrome and mast cell activation syndrome. And there's a growing recognition that there is a link between these presentations and neurodiversity. So we recognise as a commissioner that there is currently a gap in Devon for patients with these complex multi-system diseases that don't fit within our traditional services that we commission. So we're therefore undertaking significant work to explore a holistic proposal for a needs-based service for these groups of individual patients. We are trying to progress this work as quickly as possible because we recognise that this is an unmet need currently, but we don't have any specific timescales around this at the moment, but we'll be able to confirm that shortly. The aim, therefore, of this work will be to design an integrated pathway around patient symptoms and needs rather than a specific condition-based services that we've currently attempted to resolve. Therefore, this will ensure that we commission a more inclusive and responsive approach to the needs of those patients. And this pathway, therefore, will be subsequently embedded within our neighbourhood development plans across Devon and the whole peninsula. Thank you, Chair.
Okay, all done. Lovely, thank you very much. Excuse me. Let's move on to the patient vignettes. Now, Mark, for just a bit of background here, when we first started the ICBs about 3.5 years ago, we came up with the idea of actually sharing with the board specific, I think normally we've done, Lucy, 5 3-minute videos to try and pick up particular things that the board might be cited on from a patient customer type experience kind of thing. I think they've been really useful in changing a lot of the board's focus on what we've done, some of the strategies that we've taken, some of the investments that we've made. Lucy, would you concur with that? Yeah, definitely. The one thing I would like to say before we get into discussion on it is I think, Mark, you and I and colleagues will need to sit down and have a conversation about quite how we bring the patient and customer view into the service redesigns that we may be considering in the boardroom. This is unquestionably going to be part of the answer of doing that. But I think the more that we actually are going to think about services that we offer, service redesign that may be coming, and the way we're going about that, by putting the patient at the forefront of what we do, I think we just need to consider quite how we garner the information from that. And for those of you who remember from the Cornwall and Isles of Scilly board meeting, just over a year ago, before the cluster was announced, we were talking about a lived experience committee to do that. So this is all part of the general conversation that I would like to have with board members as we go through the next few weeks and months about quite what is it that we want to have as a package at this board level. And then, Mark, for you to decide in terms of whether you're happy with that and then how you want to feed that through, whether these play a ongoing part or not, or what we replace it with as we evolve. So should we move straight into the particular ones here, which is we've tried to theme them over the years. They were a bit moment by moment kind of thing, but packaging them up into a theme has really worked really well. Yeah. So Lucy, why don't you help us just sort of pick through the particular vignettes that we went through this time?
Lovely, thank you, John. And so this month's theme of films is around women's health. It marks International Women's Day and the planned publication of the National Women's Health Strategy that is due to happen in the coming weeks. We've pulled together a selection of films that highlight the challenges faced by women and some of the emerging ways we're helping to look after the health of women and girls across Cornwall, Isles of Scilly and Devon. The films show a variety of voices from women and girls of different ages, highlighting support now available for our women's health hubs, menopause care and specialist trauma-informed support for women experiencing sexual violence. These services represent positive step forwards, and the films show the differences they are making, and they align with what women say they need to. Together they demonstrate how we are doing a lot of great work in this area, but also what we need to do more of. We're using these films beyond our board meetings, so we're actually running a women's health campaign across both ICB areas and working with our partners to promote the services that some of the films feature as well. Thank you.
Okay, let's throw it open to Martin. Thank you. Yeah.
Thanks, John. Yeah, for me, actually, although the theme was women's, there was a couple of themes in here that I'd pick up, which I think were great. You know, first one is sort of use of third sector and other organisations, you know, to give a different sort of approach. And second, sort of personalisation of care. So this was more about what people really wanted rather than here you are on a standard pathway. You know, both are things I think we are looking at in how we commission things going forward. So both for me came through really strongly. And I think finally, you know, I love the sort of concept of the cancer thriver rather than the cancer survivor. So a really moving story there at the end. So thanks, John.
Yeah, very good. I think that whole point you make about personalised care, a different way of doing service offering based on what patient wants from us rather than what we offer them, I think has to be part of the reason why this needs to be part of our forward-thinking review of what we do at the start of a board meeting. Tan.
Yeah, thanks, Joyce. Look, these are great vignettes, powerful, but it's also a bit of a worrying figures and stats on where we are on women's health, actually. And I don't think we can let these vignettes pass without saying that. certainly something we can take forward with our equity strategy. And it's great to see the neighbourhood teams all in a room together in Cornwall. Certainly, place is part of addressing women's health, because one of the biggest indicators around women's health is actually around poverty and how cycles of poverty continue. So let's not celebrate these too much, if you like, because actually the story that they're telling is of unequal treatment and unmet need. So we need to have that in our plan as we go forward.
Thank you, Tan. Lincoln?
A good point to make the link to the partner update from the DSPH in Devon, in that Plymouth's annual public health report from the director is on women's health and will have quite a lot of detail there. So I recommend that to members in terms of what's happening. My report last year was similarly on the same subject. So some of the issues that Tan raised, we picked up. There's a lot of voice of women and lots of grassroots activities happening. So I think useful to read those two reports in conjunction with what the ICB is doing. Thanks.
Well, thank you. And I think having the Director of Public Health's view around the boardroom table is critically important to put it into the context as well. I'm going to come to Una next, actually.
Thank you. Just following on from that, and Ali made some comments in the chat as well. I think in the wider bit about the I'm going to say residents' voice because we come from council, and that co-production stuff, that as we move closer together and working with integrated health and actually shaping how we share our common aims, that actually council and local authorities across the patch have a real offer to help in actually getting that patient voice and actually building those services, and that, because just the nature of the relationships we have is slightly different as well. So I think there's access and perspective that we can help to really strengthen that patient voice and contribution in shaping services.
Very good, thank you, Ian. Steve next.
Well, it builds on, I think, builds on all three comments so far. That there's a wealth of information and performance content that every single organisation has got, but I don't think, John, that yet comes together in a way that the board can have easy oversight of that. So I know, as an example, from an acute hospital perspective, there is robust information about the breakdown of waiting lists by gender. That can show inequities potentially in how patients are accessing services. So my kind of question is there a way in which some of that can be drawn out in our IPR, so that on a regular basis the board can have oversight at a summary level, as well as the level of detail that Lincoln and Una have talked about in other reports as well?
Let's capture that and take that into discussions, Lucy and Mark, in terms of how we're going to build that in. We're going to go Neil, Diana, and then Frank.
Thanks, Chair. It's just looking at this and wider learnings from the vignettes. One of the important things I was noticing was, especially in terms of personalised care approach, was the ability for people to have time both to get hold of the complex problems that many of the women were presenting with, and also to develop trusted relationships. And it got me thinking that I suspect we are doing hopefully some good work for women and their families through the community health and wellbeing workers.
Very good. Diana?
Oh, yeah, thank you. From the VCSE perspective, when the conversation happens about how we move this forward, as you were just suggesting, I really feel it is so valuable to see things through a specific lens. We don't often get that opportunity. What we hear and see is lots of different lenses. And for me, what was so insightful was to hear through that one lens exactly what the impact is on communities. And the key point for me was really around the need and the focus on integration, and particularly the comments about, you know, what it is that makes people healthy wasn't necessarily about health in every situation. It was about a whole raft of things, which we all know, but I think the vignettes really, really brought that out so strongly.
And wider determinants of health. Yeah, no, quite right too. Frank?
The thing that really struck me about the meeting in Cornwall was, I know this is about women's health, but the whole audience was women. There was only one man presenting, so it's still something that is a movement rather than centre to how we deliver services. And I think the two important things that have already been said, one is it is about what they want and need, not what we're prepared to deliver, and that goes to the social sort of support. And the other is the neighbourhood is the delivery model of this for the future,
quite right.
Not a big institution.
And that's a beautiful segue as we're about to move into the neighbourhood conversation. So just, Lucy, to wrap this up, if that's all right. I think I've captured everybody who wanted to say something. And of course, Libby, this is your new portfolio, of course, as we go forward. I should be as much turning to your good self. In that slight movement between today and tomorrow, aren't we, really? Tan, I just want to build on something you said. What we're not going to do is have this kind of conversation and then just move on as if nothing was going to change. This is why we need to actually have at the start of every board meeting something that is material about, so what are we going to do about it in terms of service redesign? So it's not in the margins, it's actually built into everything that we do and everything we think. So if I can ask you to take away with Mark and think about how you're going to bring that into the story, into our board meetings, so it actually makes a cut through in terms of what we decide. So thank you, Frank. That was a perfect segue into the next item. If that's all right, we'll move on. I'm going to reach out to our colleagues. I'm not quite sure where you are, in Bodmin or in St Austell?
We're at Trelisk.
Trelisk, excellent. Well, welcome Dr Minal Bakai and your colleagues. So where would you like to start? We're in your hands. We've got half an hour with you.
I bet Chris was going to kick off.
Chris?
Well, very quickly to kick off. So, yeah, thank you, Minal, for coming all the way down to the southwest, and thank you for your energy and passion and sort of the national leadership role in sort of shaping neighbourhoods. I know there's a full room, and we've got NAPC colleagues with us as well as the entire neighbourhood team in Cornwall. I think the three things we're keen for Minal to give her expert opinion on is why neighbourhoods, reflect on what she's learned about what we're doing in Cornwall, and sort of an honest, as it were, marking, and also her recommendations on what next, in particular what next in the context of now we're in a cluster with Devon. So over to Minal.
Over to you, Minal. Welcome.
Thank you, and hi everybody. Just by way of introduction, I'm a GP myself in North West London. I'm National Director for Primary Care and Community Transformation, and I'm the SRO for the National Neighbourhood Health Implementation Programme. And it's absolutely wonderful to be in Cornwall because you are one of our 43 trailblazer sites, but you are absolutely superstars in the neighbourhood health space. I just want to say a big thank you to the team here for all of the hard work that they've been doing in driving this agenda forwards. I have the privilege in this role to visit all of our 43 sites. I'm at 40 out of 43 so far, so last few this week. But I thought I'd share a few reflections on what I think really makes neighbourhood health work, some of the results that we're seeing across the country, and then a few reflections on the work that's specifically happening in Cornwall. So, the vision for neighbourhood health is a broad vision. It's very much centred around enabling people to live gloriously ordinary lives, because we know that the majority of health is much wider than health care. It is mostly shaped outside of clinical settings, in people's homes, in workplaces, in schools. And the outcomes in particular are shaped by the million-plus interactions and decisions that are happening every day at the front line, whether that's through primary care, in people's living rooms, faith spaces, wellbeing centres, and so forth. And so the key to driving a successful neighbourhood health model is by developing the enabling conditions for high quality decision making, not just high quality delivery. Because what we know is there's nothing more useless than driving an ineffective intervention, but more efficiently. So it's about both. And to make high quality decisions, we really need to understand what matters to the person, what matters to their family, and take that biopsychosocial holistic approach to care. And a lot of that information is held both within communities and individuals themselves, but across partners. And that's why that partnership approach is absolutely fundamental to success. So neighbourhood health does not work if we do not enable credible, strong, trusted relationships and partnerships. And so some of the key things that are emerging as I'm travelling across the country and through the national work is that we've certainly created a national movement of change, but it's really important to keep our workforce galvanised around this agenda, because neighbourhood health will not work if we have a disenfranchised workforce that feel alienated from this agenda for change. And that means that we need to focus on priorities that matter to everybody and to all partners. And what we're seeing through the NHIP, the National Neighbourhood Implementation Programme, is a really strong community of practice of 43 that are supporting each other and accelerating collaboratively along this journey. But in particular, connecting leaders with frontline practitioners across organisations and with communities around a shared mission, but really importantly, local ownership. The second, as I mentioned, is credible partnerships. So those time and space to build those trusted relationships, the psychological safety to have those very difficult conversations around risk, finances and financial discipline, and collective problem solving. So it's more than just a shared mission, but it's also about a collective problem. So if you go to Doncaster, they talk about the Doncaster gap. They don't talk about the FT's deficit, because it's a shared problem with a shared mission around reciprocity, shared resourcing, and solving it together. I think the third thing is that there are comprehensive neighbourhood models that are emerging, and I'd absolutely highlight Cornwall as one of those sites that's really driving this forwards. So this is about combining health creation, so connecting people to purpose, to place, and to communities, because if we don't get that right, our clinical interventions will not work. And there's a whole host of evidence to say that if people don't have that sense of belonging, then they are not going to take their medications, they are not going to engage in health screening and preventative activities. So that is an absolute foundation if we want to shift some of the demand pressures we have on the system. Then that drives greater prevention, which enables us to do proactive care, and then connecting proactive care with urgent crisis response. So what are we seeing? We're seeing population health management data being used alongside local community insight to identify target populations. And while neighbourhood health is absolutely a whole population approach, you've got to start somewhere. The second is really coordinating multi-agency teams around those populations, providing both proactive care and connecting that into place-wide urgent escalation crisis response services, and streamlining the way that we provide those community response services. So having a single front door, but then being able to really triage people into whether it's virtual wards, urgent community response, hospital at home, SDEC, whatever it is, but making sure that we're using that resource without duplication of services. We're using that resource on a rotational basis, so particularly with community services across the country, they are shifting so therapy resources from the acute and the wards into some of those community services to support that outreach work. And it's to create that join up between the two. The second is really making sure we're joining up physical health with mental health, and we're not seeing them as silos. So we're not having a neighbourhood health centre, mental health centre, a family hub. It's how do we bring some of these things together in a sensible and coherent way. And then, of course, it's making sure we're embedding VCSE at every point along that journey, and not just in the community, but also on the wards. So we're stopping people deconditioning wherever they are, particularly on the wards. People are sat in a bed, not doing very much. So having creative health, having group activities, keeps people supported in a way that we can get them home more independently. The fourth thing is leadership, and that's absolutely critical to success. And we're seeing new leadership behaviours emerge, particularly boundary-spanning roles or system stewards. It's an incredibly difficult role to hold within the system, and so we can't expect people to just do this on top of their day jobs. And so it's been great to see systems across the country really investing in both leadership development, and I would specifically say leadership development for primary care, where that investment hasn't existed for a decade, and in our voluntary sector colleagues. Because those roles are going to be critical to success, but it's also giving people time and headspace to do those roles. So it's not a PCN clinical director also being the neighbourhood lead who's also trying to be the strategic lead. So it's creating time and headspace and formal roles for that leadership around neighbourhood health. The fifth thing I would say is durable place structures. So if we want to shift left, we've got to create the place structures. And so you'll see in the neighbourhood framework really talk about devolution and passing greater responsibility to capable places. So it's creating durable place structures that are able to take on that responsibility for devolved budgets, operational decision-making authority, aligned clinical and financial risk management. And that requires clear strategic and operational leadership. From the blueprint that was presented to me this morning, that is really clear that is being developed in Cornwall. Got a very clear leadership team with clear strategic and operational leads, clear clinical neighbourhood leadership, and clear governance structures, so deciding what needs to be hyperlocal, what needs to be consistent, who makes what decision, who holds the accountability, and particularly that distributed leadership, so that not everybody's trying to be the leader for everything, but we are utilising the strengths of all partners to lead the areas that make best sense for them. But it's also about creating that permissive culture. So we're not having layers of governance before we can make any changes. It's that element of subsidiarity. So giving frontline practitioners the ability to work differently and to change ways of working. And often it's the operational connection and collaboration that is more important than the formal governance. And that's names, that's contact numbers, not just org charts. And I'm starting to see these structures develop across all of the places that we're working with in the programme. Some are more mature than others, but I think as you get accountability, outcomes, money and authority to align, you remove some of the tensions that stop us from moving quickly. So that alignment is absolutely key. On 6, that's strategic commissioning. So as you all know, the neighbourhood framework and ICB assurance is starting to change or evolve over 26-27. So ICB is making that investment in the left shift, both in terms of resource, funding, but also us expecting to see a left shift in activity. And it's great to see systems around the country investing between 1 to 2.5% of budgets into that left shift. And we will see performance frameworks and our assurance culture shifting to be focusing on us being better partners within place. So providers being better partners in place, not just focusing on financial balance. And actually moving away from this arbitrary sort of division between recovery and reform, because neighbourhood health is the answer to some of our financial challenges and sustainability challenges that we're facing as a system. And where systems have bold plans, regardless of their financial recovery status, they are being backed by NHS leadership. So I've had 3 places across our NHIP sites who have been struggling with getting their plans invested in, and Jim and Elizabeth and others have lent in to support them. So they are willing to give the head cover to systems if there is a credible plan that sits behind that. I think that seventh thing I would say is national intent. So we are moving away from conversations that are purely dominated by acute operational performance, as I mentioned, and the neighbourhood framework sets out a very clear ambition around a focus on prevention, proactive, personalised care, and that being a system-wide focus going forwards. It gives power to health and wellbeing boards over 26, 27. They are going to have to work with communities to understand what local priorities and local outcomes look like. And that gives us a real opportunity to ground neighbourhood health in place priorities and community priorities. And neighbourhood health and wellbeing boards will have to sign off neighbourhood health plans, which then obviously go to the ICB for sign off. And there is an action and learning network that's being set up for strategic commissioners, the ICBs, local authorities, and place partnerships to come to work together to look at what outcome-based contracting looks like, year of care, blended care payments look like, build that technical capability, but really importantly, build the relationships around strategic co-production of those plans and frameworks. And that is going to be critical if we want this to work effectively and to work for the residents of Cornwall and Devon. And then, of course, I would repeat this over and over, but VCSE, VCSE, VCSE. I cannot emphasise how important the role of our VCSE organisations are in driving this left shift, because the golden or the North Star for neighbourhood health, while it will of course reduce hospital admissions and outpatient activity, the North Star that's going to keep our system sustainable is person activation. If we can support individuals, families and communities to have the confidence and the ability to better look after their own health and well-being and their long-term conditions, then that is going to drive the biggest productivity gain for our systems. It's our biggest untapped resource. We have digital technologies that can help us accelerate that. And so it's how we support that real shift and focus to prevention. And we are working with the Office of Impact Economy and the Cabinet Office to bring not just public finance into this space, but blended finance, so impact investment from philanthropy, social finance, corporate finance, to essentially support VCSE capacity and infrastructure to fund some of that upstream activity. That is not a substitute for commissioning and good commissioning, but it can help catalyse some of the key interventions that are going to drive the biggest impact, and it starts to bridge partners around those shared outcomes. And very much through the programme, we are embedding whole person outcomes. So we have developed data infrastructure that allows us to connect PROMs, PREMs and person activation at a patient level to service utilisation. Because as I'm going around the country and I'm looking at all of the data around avoidable admissions, actually the interventions are not clinical. So beyond a medication review, what those individuals and families need are VCSE input, social care input, wider local authority input to support with housing and food poverty and that sort of thing, and psychological support, so mental health support, not psychiatric support. And so we've got to make sure that when we are looking at our data, we're looking at the whole picture, because traditionally what we've done is we've gone, oh, we've got lots of people turning up to hospital, let's put more resource into the hospital, more capacity into the hospital to deal with it. And instead, if you look at the whole person picture, you can see that they're socially isolated, their care's not clearly coordinated, they have a partner who is their main carer who's become unwell. And actually, therefore, we will never solve, we just end up going around in a vicious cycle. We never solve the right problem.
I think we completely agree with you. Yeah, I think we completely agree with you.
So I guess what do I see for Cornwall? I think you're doing absolutely all of the right things. You've got really strong foundations. The partnership culture is palpable. The cultural change is palpable. You've got the right models of care. You've got the outcomes framework, you've got the, I would say invest more in your digital infrastructure to start joining this up so you can work as an integrated multi-agency team properly, virtually. I know we've talked about estates, and there's some work that I will do to connect teams back up to our national estates teams to support you. But keep going. And I suppose my question or reflection now is that as you merge as a cluster, how do you take the energy and the momentum, and in particular the activation of the workforce that you've built in Cornwall, and start to spread that across to Devon? And I think I'll just end with, the stats are really, really compelling. So everywhere I go, and I was in Rochdale last week, they've done this across all of Rochdale, and they've seen a 27% reduction in emergency admissions. They've seen a 1.6% reduction in ED attends, 43% of reduction in nursing home care, 24% reduction in residential care. But fundamentally, that's from the Andy Burnham kind of live well mantra, that social operating model, where they have focused both on prevention and proactive care, as well as streamlining how the NHS services work in a more coordinated way.
Very good. Very happy to hear you say all those things. We're honoured to have you down here, and thank you for those comments. I'm going to get Ewan. You want to come first? Ewan.
Thank you. Really welcome all your reflections. If taking messages back to the centre, I think it's really VCSE is very important, but also I think you need to really make clear the importance of local authority in this. If you're wanting a sense of belonging, that's kind of our stock and trade and our localism agenda. And people actually want to spend most of their lives not in health, and we spend a long time and a lot of our time working with people getting on with their lives to achieve those ambitions. So it's not just the prevention and those sort of services, it is about that engagement in how people live their lives in communities and that upstream. I think as well, just our local experience, digital is important, but we are actually very digitally vulnerable, and Storm Goretti did demonstrate that for us, and we have concerns about digital inequalities as well. So I would be having an ask to government as well in helping us and in the rural areas in other parts of the country, that in actually fixing our problems and the challenges we have it's easier in the urban areas, and so this is from the rural areas that we need to actually have a different look at resources there as well to achieve the things that you rightly are saying. There's some complexity here that we would actually want support from government about.
Very good. So what we're going to do is we're going to go. I'm going to go to Ali next, then Tan, Steve, and Chris. I'm going to ask you to wrap up then. All right, because I'm conscious of your time and ours. So, Ali next, please.
Thank you, Chair. Good morning. I'm Ali Bullman. I'm one of the local authority partner members on the ICB. I just wanted to thank you, first of all, for coming to Cornwall. I apologise that I wasn't there to meet you this morning. Unfortunately, I'm not great. You probably wouldn't have appreciated me being in the room today. But I just wanted to be really, really, and echo what Ewan said, really, really clear about the local authority's position on this. We're absolutely committed to working with our partners and our residents. We've got a very strong co-production framework in place across the council where we work with our residents to really understand what matters to them and what makes a difference. And I think that, we touched on earlier the broader determinants of health. And I think, and I passionately believe this, we need to think about different interventions to deliver better outcomes for our residents and reduce the demand on high-cost services such as the NHS, adult social care, children's services. So I just wanted to give the local authorities commitment to that way of working. We've got a value in local strategy, which is absolutely aligned to the integrated neighbourhood health and wellbeing work that we're doing. Ewan has been leading on a kind of system-wide prevention strategy. We've got a really robust partnership carer strategy. So we're absolutely aligned across Cornwall, working in partnership, and we've got those really good relationships, I think, to really deliver on this as well for our residents. So I just wanted to say that, and thank you for coming to Cornwall. Thanks. Thanks, Chair.
Thank you. Tom?
What an opportunity to celebrate. Some really good work here, folks, in driving some of this neighbourhood development. It's taken us some time to get there, and it's not been a straight journey, has it? There's been some ups and downs along the way, particularly around how we're going to measure what we do. We know we've only got one envelope of finance, and so when we move things, it is difficult. So well done for being brave. There's always a yes and, isn't there? So yes, and we need to do much, much more of this because we know that it impacts. So we've done some really good work in place, and that's very important. The other thing I'd like to see us doing more of is working with those people that, wherever they are, that have the most complex lives. Developing our trauma-informed approach. And Minal, I was wondering if there's anywhere across the country that's doing anything like that we could learn from, and how working in a joined-up way with councils, local authorities, with charities and others, and predominantly with the people themselves, about how we work to join up their journey of health and well-being. And along that line, I'd really like us to find up with another word for patient activation. It does sound a little bit like they've been slugs and laying around and not doing anything very nice. So it would be really good to work on that and see if we can come up with something that's a bit more empowering and a bit more listening to people. And really, I suppose the challenge for us all is 1.5 to 2% enough? Should we not be aspiring for more than this when we know that it works? This 1.5 to 2% is not really transformational. It's not really the left shift that we really need to see if we're actually going to address the issues that we've got within our health and social care and whole society. Thank you.
Thank you, Tan. Steve?
Yeah, thank you. Can I echo those comments, and thank you for coming to Cornwall and the Isles of Scilly, and apologies I'm not there in Cornwall in person. John, this is clearly critical for patient outcomes and for improved health, and I also think addressing inequity. I just want to make the point that this is also a really important part of how we eliminate corridor care across the peninsula. There's a huge amount of work underway in each of the 4 acute trusts to do just that, but this directly supports that as well, and we should recognise that. So my question or comment is, for all of us, how do we increase the pace? And how do we really drive this forward so we can maximise the kind of benefits that have just been outlined?
Thank you. Lenka?
Thanks. Really helpful presentation, and good to see the resonance with real joined-up care, locally, including, as you say, voluntary and local authorities. I wondered something about the principle of allowing the money to follow the intervention. And one of the challenges I think we face is that we're quite happy where it's a medical intervention or a medicine that we will pay for it. But for example, and I would say the evidence might suggest that if you help people with damp and mold in their houses, and I'm not suggesting it's easy in implementation, but you might actually reduce the medication spent on inhalers and so forth. What we haven't been good at doing is to allow that money to follow. And the principle that would get over the 1%, 2% budget is if we were to allow money to be spent for non-medical interventions that have proven clinical benefit. Am I making the point?
Yeah, you are.
Yeah, and that would flow money into the VCSE. It would flow appropriately where it is. And also, how can we use personal budgets more? Because we know there's good evidence around that, particularly on community interventions for mental health, where people are in charge, they can commission to suit the things that allow them. So that would be the one addition that I would say that would really help us shift meaningfully into that left space.
Very good. Thank you. Frank?
Thank you, Minal. As a GP in Devon, that was absolute music to my ears, and can I assure you that we are ready to copy Cornwall and try and advance things. In terms of advancing things, I think this is more about community development than about us. It's not about integrated neighbourhood teams that are very medicalised. We absolutely have to get those communities to be self-developing. And I give an example. I went to a children's park run in Tiverton that started about 2 months ago with my grandchild. There were probably 100 people at it. There were community people actually linking with each other and the relationships that will build out of that we aren't measuring, aren't actually aware of, that support each other going forward will be huge. So this is about a move to a social model of care in terms of an asset-based community development, and we absolutely have to think beyond what we're used to thinking about if neighbourhoods and communities are going to be what they could be.
Okay, thank you. We're going to go 2 more comments, and then I'm going to try and wrap up if that's all right. So, Chris, and then I think, Mark, you want to add something? No, fine. Okay, Chris.
Yeah, just thanks, Manal and the team in the room. If I reflect on some of the comments that have been made, but and the question I want to put is almost for the board. So, what does the board need to have here? And I think fundamentally this is about impact. So, what's the impact that we're trying to do here? The impact we've articulated in Cornwall is in the blueprint. And the blueprint gives these 8 outcomes, which I think if the board was to have that real strong lens and focus on those 8 outcomes, it will answer all of these questions. And those outcomes, I would say to the board, that's what we should be asking for trajectories and measurement. Those 8 outcomes are a health literate population, a trusted clinical teams, a resilient, happy workforce, improving the population health metrics, but more importantly, reducing inequities, reducing acute demand. That's one of the 8 we need to actually measure. And we need to be within the financial envelope. We can, from the get-go, we can say this has to operate within the financial envelope. And finally, the final 8 is we need to make sure we can demonstrate better citizen and user experience. Those 8 are the outcomes of our blueprint. And I think they are in keeping with the national framework, but actually go a little bit more to show the real impact we want to have as a cluster.
Okay, thank you. So to try and wrap up, I too want to thank you, Manal, for coming down and sharing your thoughts and speaking on, because it's not just this short window of time with us. I know you're with everyone down there. I think my thoughts on this would be as follows. 2% of Cornwall's budget is twice what we're even aspiring to do in year 3, by the way, everyone. So I want to build on Tan's point. The scale of what we need to do here has to be beyond where we're at the moment. We need to empower people more to be able to be ready to scale up and do that. Chris, you'll know I'm tired of celebrating good pilots. All right, this is about celebrating the good pilot and then scaling what works. And we know it works. You'll be capturing the evidence that it works. And the more you can scale it, the better benefit for people, etc. There's a huge tension, which I'm always grateful we've got Katrina in the room. There's always a huge tension as we start to empower people that somebody somewhere actually wants to put in a governance structure to stop that empowerment. Not deliberately to stop it, but to have a sort of grip and control on it. So, Chris, I look to you on behalf of the board to make sure that with Katrina's help and others' help, we don't put those mechanisms in place, but we do actually truly empower our neighbourhood leadership cohort. And the other thing, Chris, I would ask you to maybe touch on with Manal while she's down here is you've heard our 2 colleagues from the Cornwall Council talk about the importance of working together. There is some governance structure at the Health and Wellbeing Board that's linking in with the Joint Committee of the Integrated Care Partnership that Diana was talking earlier on about some of the things about the wider determinants of health. This is how we can actually both in the helicopter and in the coal mine and make sure we leverage all the things at place level, not just the things that we as an ICB can control. And that's the true value of partnership at system level. So I can ask you just to leverage those points and keep us abreast as the board when it's working, but keep us abreast where it's either institutions or things are getting in the way of that scaling. Does that work for you, Chris? Manal, thank you ever so much. I think that's been a very helpful conversation for us to have and completely in the direction of travel. And I hope that you can come back in a year's time and we'll have more than doubled our efforts in Cornwall. And in fact, we'll have got Devon well on the way to actually aligning its work with the same way of delivering that we do in Cornwall. Thank you very much, Manal. Have a very good day down in Trelisk.
Thanks, Chris.
Thank you. Take care. Bye-bye. Very good. Yeah. Let's move on from there. Now, is there anything we need to minute from that, by the way? No, very good. Okay, so we're going to go on to my chair's report. So a few, I'll take it as read as always, but there's a few bits in there which are more in my report, primarily the company secretary. I can think of anywhere else probably to put some of it in terms of some of the structured bits to do with the terms of reference. So the terms of reference changes are because primarily from the 1st of April, we actually have a new cluster set of executives, and the terms of reference at the moment refer to the old job roles that we've got. And therefore, as we're starting to move into a cluster, we need to move into the new group. So primarily, the Neighbourhood Health Improvement Committee, the People Customer Experience and Equity Committee, and our South West Planning Committees have terms of reference that still refer back to some of the old roles. What I'm looking for is for your support as we go through those to build on that. I'm going to pause there. Is there anything that anyone wants to raise on those? They should be pretty straightforward. Yes, please.
I think just to highlight that, as most board members will be aware, we're undertaking a review of our corporate governance framework and considering how the committees have been operating, including the membership of the committees, which we will be bringing back to the board in draft, in private in April, and then for final approval at the May board meeting. So I do think it's important to flag that this isn't the final look at these, the membership and these terms of reference. There is other work ongoing.
Yeah, this just allows us from the 1st of April to move from the current ones to the new ones. Okay, so I'll come back to the recommendations in a bit. I'm going to be asking you to note the Chair's action since we last met, a very significant award of the contract, the provision of integrated urgent care services to Kernow Health Community Interest Company. Is there any particular questions on that particular item anyone wants to raise? No? I'll get to that as a recommendation in a second. A few other points just to share, really, that I probably could have put in and one I couldn't have put in when I was writing it. With the appointment of those executives, of course, I just wanted everyone to recognise that up until the 1st of April, we have been clustering with two sets of executives from Cornwall, the Isles of Scilly and from Devon, who, by their own positions in their roles, were conflicted in their ability to actually be in the decision-making process. And for those who aren't aware of it, and particularly as we're in a public environment, I thought I'd just deal on it again, is at the start of the cluster, we actually set up a transition steering group. I happen to chair that. Tan is on there as a non-exec. But all of the senior executives were on part of that. And it was been principally that transition steering group that has been the position up till now that's been making most of the decisions. I look to you, Patrick, to endorse that as we've gone through that. Thank you for endorsing that. I also wanted to just do a little shout out. As I was thanking everyone earlier on, I wanted to shout out to the executive group from groups from both Cornwall, Isles of Scilly and for Devon for working through what has been on occasions difficult, different methodologies that have worked, trying to come together as one team. People's own roles at risk as we go through that and that movement. So I wanted to say thank you to them. I also wanted to say thank you to the advice that we've been given, particularly to Tan and myself, and to the whole non-execs who effectively, as the non-exec group, we were concluding the consultation phase one. Janet King, who is an external independent HR advisor, and to Alison Williams, another external person who stood in as effectively giving us chief executive advice, as she wasn't conflicted in the process. And I just wanted people to recognise the huge amount of effort that's gone in, both from some independent colleagues and from our two executive groups, to getting us through to this point in time. Well, I'm on that point, Patrick. Is there anything you would like to raise in terms of the way in which we've gone about getting to this point? Happy with that? Thank you very much. Only other thing to update you on is there was an interview panel for a replacement of Salma as our non-executive director. I can confirm there was a unanimous decision by that appointment panel for the next non-exec director to be joining us. I can't tell you who yet, but we're very pleased to actually endorse that individual. And as soon as we can announce that, we will be doing that. And we just need to work out how quickly they can arrive. But they'll certainly be here for our next board meeting. Okay. Susan.
Thanks, Chair. Just whilst you're talking about the new executive team, could I also just say thank you to those in the executive team who haven't secured roles for one reason or another, but continue to work incredibly hard. Yeah. I'm thinking particularly Tracy, who's done a sterling job. So just to say thank you and acknowledge those people that won't be coming forward into the team. Thank you.
Completely agree, Tracy. I didn't want to name individuals at the front, but because it's a difficult situation, but as you have done, thank you for everything that you've done for us. There are other colleagues in Devon as well, but it's been an immense privilege working with you up to this point, and I'm sure there'll be discussions going on as we go forward, so thank you for that. And there are colleagues also in Devon affected by that as well, but I'll leave Patrick for you to conclude those arrangements before we share those. All right. Okay. Anything else on my report before I move to the recommendations that I need to more formally get minuted? No? Okay, so here comes the formal bit. So we're going to note the content of the report. We're going to approve the proposed terms of reference changes for the South West Peninsula Neighbourhood Health and Improvement Committee, for the People, Customer Experience and Equity Committee, and for the South West Peninsula Planning Committee. So we'll take that as a decision. And we're formally noting the use of the Chair's action to note in respect to the award of the contract, basically for Kerno Health Community Interest Company. Are we happy with that? Lovely. Anything else you want me to cover off?
As long as we recognise, John, we're obviously going to look at those through Philippa's review.
Yep. Okay, so let's move on to the Chief Executive report, please.
I just think I want to say I'm delighted to come back into the Devon and Cornwall system. I look forward to working with everybody. I've got a lot of people to see and talk to and listen to, and some of that will be controlled by events, some of by my diary management. And so I'm really looking forward to working with you all. I'd just like to draw your attention to two things, really. One, the kind of priorities, really, in section 3 of the report that we will need to be concentrating on, given the welter of challenges we've got. And what runs through that is clearly some of the things we've heard in the earlier patient vignettes, and a strong theme around working with partners, because we're all in it together. Fundamentally, and need to work together effectively for our patients and our communities. And secondly, Tracy, I think we need to note the 5-year plan, don't we? Do you want to just come in there?
Thank you. Yes, it's the technical document that we've attached, which has gone to NHS. We will bring a more public-facing version back. It hasn't yet been signed off, which is why it's an appendix rather than a substantive agenda item, but it is important it comes here today, because it incorporates the joint forward plan requirements around our statutory duties. So there is an annex which demonstrates how that 5-year plan fulfils the duties of the joint forward plan, which we'll need to then publicly add to our website before the end of the month.
Any questions for Mark on his... Steve?
It's not a question, it's just a comment on the plan. I know all board members are aware of this from the content of the plan, but one of the challenges from an RCHT perspective is RTT improvement. NHS England requires a 7% RTT improvement, and as board members are aware, the latest submission had been a 1% improvement rather than a 7% improvement, which directly arises out of the temporary productivity impact of implementing electronic patient record. That's still the case, but the comment I wanted to make, Mark, is colleagues continue to take every possible action and consideration on what further steps can be taken to improve that RTT position. So even though that has been the latest submission, RCHT colleagues continue to work internally and closely with ICB colleagues through Tracy and other colleagues to identify any further options that would help an improved position.
I know those conversations are going on, Steve, so thanks for raising it. I mean, I think we're going to need to look at nudging that further up, as you're well aware. So I think the discussions will have to happen over the next week or so, despite some of the deadlines we're getting told.
Okay, so just before we move to the formalities, I just want to tease out one of the items in here, which is just recognising again Royal Cornwall's segment 1, Steve. Particularly pertinent as your last board meeting, so again thank you for that. But also, for those who haven't spotted, its Cornwall Foundation Trust has moved to a 3. That is not insignificant, colleagues, given the sort of the metrics that mental health organisations have to get over the bar for. So, can you pass on when you next see Debbie, Steve, for me?
Yeah, absolutely.
Great. Thank you very much. Okay, so the formalities of this. Okay, so the recommendations that we've got here to note the statutory requirement of the ICB has to demonstrate how in our meetings we had the legal duties to publish by the 31st of March on our website to fulfil our joint forward plans. Are you happy with the appendix that Tracy's raised with us? Everybody happy? Done the formalities? Done? Thank you very much. That's excellent. Thank you. So now we're moving on to the partner member reports first of all. So in the order in which my notes are gone here, I'm not picking in particular order, we're going to start with local authorities, and we're going to start with Ali, would you like to start?
Thanks, Chair. Yeah, that's brilliant. I'll take the reports as read. Unfortunately, you do seem to have ended up with 2 reports from me this month, but I think it was because I put one in for one of our sessions when they weren't required. So there's a little bit of duplication, and the shorter one is the up-to-date one. But I did want to just give a verbal update, if I can, from a few things from the Isles of Scilly. Susan Butcher started as the joint DCS and DAS. So congratulations to Susan, and I've been in a meeting with Susan this week already, and she seems like that she's absolutely going to be on it, so that's really, really positive. And also, Russell asked me to pass on that they are about to start transitioning into the new care home, which is excellent news. So they're the 2 things that didn't quite make the report.
Okay.
Thanks, Chair.
Thank you very much. We're going to move to Anne-Marie. Can I just make an observation, Anne-Marie? I thought it was a really strong, well-balanced report from all 3 councils in Devon, which is lovely to see, so thank you for that. I'm just going to throw it out there. I think we need to have maybe a conversation about the mechanism for recommendations and that kind of thing. So what I'm going to do, if it's all right with you, is give you the opportunity to have an update, and then probably more note the outcomes, and then we'll ask the executive group to take that away. But please, we're in your hands.
And Chair, I absolutely recognise that, and it was finalised whilst I was on leave. It had been submitted, so I realised it had gone slightly further than I had expected it to in my absence, so apologies. And indeed, Chair, this is the first then substantive report, so it is longer, colleagues, you'll be pleased to know, than you'll receive in the future. But clearly wanting to set out particularly the inspection positions on both children's social care, SEND and adult social care inspection, so that there's that awareness across the board in that respect. I think, and assuming that colleagues have read it, it's probably important to highlight that the SEND white paper was published last month. There is, whilst consultation is ongoing in that respect, there is the requirement for local areas to prepare their reform plans, and for those to be submitted in June, and therefore it's critical and very time-limited work that needs to happen between us. But I think it's also, and the report does highlight the continued concerns in the SEND arena in terms of the delays in timeliness of assessments and the impact that has on our families. The paper does raise issues in terms of joint commissioning, and clearly we've got a joint commissioning report on the agenda today. And there have been a number of references to the restructure within the ICB. I think it's important to note that as local authorities, our teams on the ground are feeling the impact of that, and probably inevitable that there would be that, but it's important that at an exec-to-exec level there is that ongoing dialogue to help to manage and support colleagues going through the next stages of the restructure, but also so that we can manage that within our organisation similarly, Chair.
Thank you, and I think it was a really helpful paper in terms of bringing the breadth of issues across the 3 councils for the board's awareness. So I think one of the things, unless Mark and you and the team want to respond to it, I think one of the things we should definitely say about it is that we need to take that away at executive to executive level, get clarity on what next, unless there's anything else you want to add to that.
No, I think that's absolutely right.
Yeah. Does that work for you, Anne-Marie?
Absolutely.
Fine. While we're on your area as a statutory partner member, I wanted to raise what happened on Monday with Devon County Council's Health and Scrutiny Committee, because I think it would be helpful, bearing in mind Philip and I went to that we try and have a brief discussion about what we're going to do with our own governance around the boardroom table. There is a couple of letters that have been written to me as the chair from Devon County Council, and principally about having their chief executive in effect on our board. Our position to date has been that we set up our constitution on the 1st of September that allows effectively for statutory partner member to represent, as you do, all three councils. You're not here, neither for that matter is Steve for that matter, and Sam, for example. You're not here as RCHT or RDUH or as Torbay, and that's written into the legislation. So I think one of the things that I'm just looking for commentary on and hopefully support on is to stay where we are at the moment, actually having a statutory partner member for Devon and one for Cornwall, and the Isles of Scilly, actually retaining a position of having the directors of public health around the table. I think we've seen today example of yourself, Ewan and Lincoln, contributing significantly in terms of the way in which public health feeds into the way in which our board has. And one of the things that NHSE regional director has asked me to make sure we do in Devon is to make sure that we actually get the integrated care partnership back up and running. So we need to actually have that conversation. But we have spoken to each of the three councils about making sure that we work with their health and wellbeing boards and have discussions akin to what we've done in Cornwall and the Isles of Scilly about having a re-energised health and wellbeing board with, as a joint committee, principally making sure we're fulfilling some of the integrated care partnership strategic requirements of the wider determinants of health, the neighbourhood work that's coming down. Place is going to be more important as we go forward. But the key question is I wanted people's views on the Constitution. So my suggestion to the board is what I put to the Devon County Council Committee, Health and Scrutiny Committee, was there are three roles on our Devon board: the statutory partner member, the director for public health, and the chair of the integrated care partnership. And Mary, I will be writing to you formally to ask for the integrated care partnership to be set up on the back of this. But I think it is important that we note that it is down to the three councils to appoint who is the statutory partner member, for the three councils to appoint who is the public health representative, and for that matter, the three councils to decide who is the integrated care partnership chair. Personally, I'm content with the way it is at the moment. But I think that is entirely within the gift of the three councils. So before I ask Anne-Marie to respond, and possibly others, can I get the board's view on this, Steve?
Yeah, my immediate thought would be it would risk making the board unmanageable. If we took that approach in principle, that could lead to all local authorities being in attendance or members, that could lead to all NHS partner organisations being members, and I think there would be an immediate challenge in terms of how a board would be able to operate with that many people. I also think it would undermine the principles that you just described in terms of what's expected nationally.
All right, thank you. Frank?
I think it's incredibly important to think about what we're trying to achieve. We're trying to move from organisational sort of dominance to what the populations need, and therefore getting the ICP up and running again and a wider engagement is really important. I also think we're dealing with population health, and so a public health voice again is really, really important.
Thank you very much. Sam?
Yeah, John, from the perspective of the acutes, we fully support your proposal. I mean, I would agree with what Frank's just said. I think the other thing is, as you've said, we really need to push on now with the place-based arrangements, and that would be one of the spaces we would see where partners can come together at that level to really drive some of the change.
Thank you. Una?
I think I'm very happy to stay with the arrangements as are. From a point of view of Director of Public Health, I think our place at the table is important in actually achieving the aims of the 10-year plan, and also if we're not here, I think that it would provide a risk of a big gap of missing out on opportunities. And also to point out, I'm representing two Directors of Public Health here as well, so it's incumbent on me, and I think all partners, is how we actually communicate back to our partners that if that's the gap that's missing, that's the first thing I think needs to be looked at.
Thank you. Ali?
Yeah, I was going to say similar to Ewan. Actually, Director of Public Health, I think it's critical to be around the table, and Ewan does represent both the Isles of Scilly and Cornwall Council in that role. But also, you know, from a Cornwall and Isles of Scilly perspective, both Russell and Kate Canali, as chief execs, have put me forward as the lead member, lead executive for our relationship with the NHS, to represent both councils at this board. So we're content with that position as it stands, Chair. Thanks.
Thank you. Phil?
Yeah, I endorse everything the other partner members have said, so I don't have an alternative view.
Thank you. Anybody else? No? Anne-Marie?
So, Chair, clearly Devon County Council have taken a particular position and are very clear as to their desire at this moment. I would reflect that looking more widely across Devon, these arrangements have been in place now for a number of years and the position rotating. And certainly from a Torbay and Plymouth perspective, we are not asking for such a change, Chair. However, what we have done, and just for this meeting, it's been the first time that it's happened, is that both my fellow chief executives in Devon and Plymouth have had access to the private board papers, which they hadn't had before. And they've absolutely contributed and have been texting me this morning in terms of issues that they want to raise. So absolutely that dialogue is happening between us. But notwithstanding that, Devon are still very clear in terms of their position.
Devon County Council.
Devon County Council, yes. And I can't say anything more on their behalf.
No, but it's not your position as Torbay nor Plymouth, is my understanding.
Correct, yes.
Correct.
However, Chair, clearly, were the board minded to accept Devon coming on, at that point, and I think it's been referenced, it would then have to be an all or nothing scenario. Right. There wouldn't be a justification from my perspective, to allow one additional. At that point, it would become an all or nothing scenario.
Really, I think I'm just asking for the board to endorse. We're staying, everyone's nodding, we're staying as we are. And in my response to the chair of the Health and Scrutiny Committee, I will be replying on behalf of the board. Thank you very much, everyone. Okay, so we'll move on. Just on the executive arrangements, Mark, will you pick that up with each of the chief executives, or how do you plan to do that?
Yes, I want to talk to Anne-Marie, Tracy, and Donna, and Alison, and Alison CEO around what the arrangements are for partnership working. I also want to touch on the point that you ably raised a few moments ago in the earlier thing. We've got to look much more at commissioning integration at place level. And Chris Reed is going to be working on that, so that, without devolving resources, we've got nobody has power. So we need to think about what the nature of that working is. And for example, Anne-Marie, also the who represents us at the crucial health and wellbeing boards, really, and the OSCs. I think there's something for me just reflecting back about the real importance of engaging with public health directors in those health and wellbeing boards in a meaningful sense. And now we've got Peter Collins leading our population health work, and so on and so forth. And Chris, I think there's a need to actually bring our clinical people into the room and forge those relationships, because I think thriving health and wellbeing boards are what we're needing to do, aren't they, really?
Quite right.
The joint needs assessment,
yes,
and
Anne-Marie, definitely.
What we're doing around that.
Anne-Marie.
And I think just coming back on the exec-to-exec arrangements, I think for Cornwall, they're well-established exec-to-exec arrangements. There aren't so established exec-to-exec arrangements within Devon, and absolutely with Mark's arrival now, really wanting to do that fundamental reset, because then that's the foundational stone, isn't it? So yes, really eager for us all to pick up that conversation with Mark.
Well, thank you for making that point, because ultimately I completely endorse that Devon's not been in the same space until Mark's arrival, but ultimately the exec arrangements are going to take us forward, I suspect here. Okay, thank you very much, everyone. So let's move on to Steve, first of all.
Yeah, thank you. Just a couple of brief things, but firstly, John, on behalf of providers in Cornwall and the Isles of Scilly, we want to congratulate Mark on the appointment. Mark brings a wealth of exceptional experience from an NHS leadership perspective, and I know all colleagues are looking forward to working with Mark and the team, so congratulations. Then secondly, I know you've already mentioned it, John, but CFT's improvement from NOF 4 to NOF 3 is a really important milestone. The report sets out a bit more detail, so CFT's improved by 8 places in that National League table position. Very, very welcome to see. And I know Debbie and the CFT team have an absolute clear ambition to improve that further to National Oversight Framework 2 during 26-27. And the team are working really hard and making significant progress towards that. Debbie has asked me to particularly acknowledge and say thank you to Susan and the team, particularly for the support and the additional investment in community waiting list investment, which has contributed to that improved NOF position. Sure. And clearly that also contributes directly to improved access in Cornwall and the Isles of Scilly, which can only lead to improved outcomes as well. So if we can acknowledge that. If I can draw board's attention to SWAST's information. So we'll see in the report that SWAST have seen an increase in demand for their services by about 15% in January and February this year compared to January and February last year. But despite that, through system-wide efforts, we've seen about an 8% improvement in Category 1 response times and about a 20% improvement in Category 2 response times. Still not where they need to be, but a significant improvement year on year nonetheless. And then finally, it's not in the report because it was only announced yesterday. I'm sure board members are aware that resident doctors have announced 7 days of industrial action. So that's going to be a risk for all providers across, all NHS providers rather, across the Peninsula. So just in case you haven't seen that, the industrial action will be strike action, and it's scheduled from the 7th of April to the 13th of April, 7 o'clock in the morning on the 7th through to 6:59 in the morning on the 13th. At any time of year, a 7-day resident doctor industrial action is a challenge. The timing of it particularly is really a very, very significant challenge because the timing of that, of course, is immediately after the Easter long weekend, which is already a very challenged time traditionally for NHS services. So that announcement was made yesterday. NHS providers across Cornwall and the Isles of Scilly, and I know it's the case across Devon as well, have now commenced their detailed operational planning to review their existing plans and give consideration to that. But I don't think we should underestimate the scale of challenge that will come with industrial action falling in that period.
Sure. Thank you very much. Any questions? Frank?
Thank you. It's just a point that that also coincides with the introduction of the EPR in Torbay, as far as I understand it.
It does, yes. I can see Anne-Marie nodding. Okay. Let's move on to Devon. Sam?
Yeah, thanks, John. And let me just start by echoing Steve's point. We're really excited that Mark's back. We know him well, and we're looking forward to working with him. And just to place on record our thanks to Libby for holding the fort in the interim period. We're very grateful, Libby, for everything you've done for Devon. I won't go through the detail of the report, but just to say that over the last couple of months, all of the acute providers in Devon are making progress in terms of improving their waiting list position, and with the UEC sprint in March, we are seeing improved 4-hour performance as well. So that's really good to see, as well as we're on track for our various revised financial positions for the end of the year. I wanted to pick up the point that Steve had just made around industrial action, and Frank has just made around the Torbay go live. So I think members of the board are aware that we are planning to roll out our Epic instance to Torbay over the Easter period and to Plymouth later in the summer. There are meetings going on as we speak between the digital team and Torbay to work through the impact of industrial action. Currently, the plan is to continue as proposed, but I think it is a bit of a watch this space situation, and that continues to be under review. The other thing I just wanted to flag up, which isn't in the report because we've only discovered this since the report was published, is the NIHR contacted us in the last few days to say that nationally the Biomedical Research Centre competition for the next phase is going to be launched in the coming weeks. So I don't know how much members of the board know about this, and at some point we might want to have a longer discussion about research. But our biomedical research centre, hosted by Exeter University, was the first new BRC outside of the traditional areas in about 20 years. And we collectively across the peninsula have really driven the research agenda supported by that. So it's really important to a lot of what we do that we're successful in the current, the upcoming round. It will be very competitive. And I know colleagues at the university are already thinking about how they can reach out to various partners to support them in their bid. So
what would you need from our board, Sam? What would you need from our board?
I think we're going to need support from our partners, and I wonder at some point over the next few months whether we might want to have a session on research, Philippa and John, and Mark, if that was appropriate.
Yeah, in fact, I'm talking to Philip and obviously with Mark about how we as a board function, whether we start introducing development time and that kind of thing. So that might be one of the first that we do. But let's go to Steve first, and then you, and then Mark.
Yeah, strongly support that, and there's a really good track record of punching above our weight, if you like, with the centre that's just been described. Cornwall Council clearly very successful in securing NIHR investment from a research perspective a couple of years ago. RCHT similarly with Cornwall and Isles of Scilly partners securing the only commercial research development centre in the southwest region. In almost every other instance, that NIHR investment went to much larger centres. So the opportunity to work even more together to maximise these kind of opportunities, I think, is really very exciting.
Good.
You'll have noticed we both put our hands up at the same time. So yeah, we also have Plymouth as HTRC. So I think it's a really important conversation to have, because strategically we've got a bedrock, and looking at I'll put a bit in on primary care-based research, community-based wider determinants, that we could become quite a powerhouse in that area, which will also, with our neighbourhoods and where we are with that, it all is sort of coming to a place, and there's strategic longer-term thinking we need to do with the universities as well to help them figure out the areas that they want to develop as well, because at the minute you've got a lot of rising stars, they can go at any time. We need to have, as organisations, clear strategically aligned objectives for the future.
Excellent, Mark.
Yeah, I think that's bang right, and that's music to my ears, Sam. What you've just said on the BRC, I think you know actually drawing together what you and Steve are saying, given the advanced role that Cornwall have in neighbourhoods, and actually the need for Devon to develop its neighbourhood focus. I think there's a lot around the life course that we can look at here, isn't there? And I think if we looked at one of the themes in the BRC, Sam, as helping us with the life course and actually what can we do around social and clinical medicine, I think that would be really helpful. I've got my semantics slightly wrong there, Ewan, but you get what I'm saying in terms of the wider Marmot determinants. I think the other thing, John, that we should recognise is our colleagues in the secondary care sector are facing unprecedented demand. And what is incredibly impressive is the fact that we're seeing waiting times fall, and at the same time improvements to access for emergency care in the face of rising demand. And one of the things we need to be looking at as a strategic objective over the next 3 years is what can we do to look at the kind of classic demand pressures in clinical work. And what, Frank touched on this, and so did the Directors of Public Health, how we can change the nature of that demand into other demands that actually are more anticipatory, fundamentally, but also how we can change some of the supply-based demand that we've currently got with the service models we need. And one of the things I wanted to assure people is that will be a laser-like focus for us.
Very good. Excellent. Sam, do you want to come back?
Well, just to say, I agree with the comments from members of the board around the research piece. There is already a rehabilitation theme, but I think there is a lot more we could do. And John, I can be in touch with you and Philippa about potentially getting Sally Lamb from the university along, who leads the BRC.
That would be brilliant.
So
please
talk to us.
Yep, that would be brilliant. Thank you. Great. Smitesh, anything from your seat?
Thanks, Chair. Just to say welcome to Mark and nice to meet you as well. I suppose I just wanted to highlight some of the good work that continues to go on across the 4 pillars of primary care. Approximately 40% of the local requests are already being met on the same day. Pharmacy has seen almost 50% increase in pharmacy first consultations. So again, highlighting that work around making all partners more integrated with an integrated neighbourhood team. The only other things I really wanted to highlight were around the challenges, the challenging environment that we're doing this in. We have, of course, the proposed changes in the GP contract, which have been met with some consternation by the GP community, and there's an ongoing referendum which closes at noon today, I believe, to look at how the GPC and its BMA members are going to address that as a GP community. Obviously, other members have already alluded to the resident doctor strike, which will not only be challenging for secondary care, but will be challenging for primary care as well, given the number of trainees we have. And since the publication or the release of my paper, obviously we've had the neighbourhood health framework released, which we've alluded to quite significantly. So I'd just echo some of the comments there around inclusion of primary care leadership to forward that, and also more importantly, or as importantly, some strong VCSE representation. I'd like to second that from my seat.
Thank you. Frank?
I wonder whether it might be better if Pete goes first for the... Sorry, I wonder whether it might be better if Pete goes first, just because he's doing the general practice and then mine builds on top.
Okay, Pete, you go first.
Thank you. Yeah, just very quickly, you'll see from my report that Devon General Practice remains one of the most productive of all ICBs in England. And I think that's a fantastically good news story, in spite of the unprecedented demand on general practice here in Devon and nationally. So I thank Mark for noting the demand in secondary care, but it's across the system. I'm really encouraged by work I'm doing with the chief medical officers in the Price Waterhouse worker, looking at the clinical pathway and patient experience. And we all absolutely recognise that it's not the front door of the hospital now, it's the front door of the house or within the house that is so important in terms of the way we look at designing services. So we're fully engaged there. We have a meeting on the 31st of March where the GP provider community is coming together to form a community interest company to facilitate the onward delivery in Devon of neighbourhoods as our development. So we hope to bring some very good news to the next board meeting and catching up Cornwall really, really quickly. So thank you.
I'm invited by David Beardman to your to the event on the 1st of April. So I'm looking forward to coming to that. Frank?
So I said I'd build on top of that because I speak for the whole of primary care. We have great productivity across primary care, but we can't extend that hugely. If we manage to get rid of the failure demand within primary care, then there is lots and lots of capacity. Devon, in terms of dentistry, has done pretty well this year. The team working with them have been flexible and they have managed to increase productivity. They've also put out form new contracts. There is concern about the national contract and the fact there will not be the local flexibility that they have been using. In terms of Devon Primary Care Collaborative, which is dentistry, optometry, pharmacy, general practice, and the VCSE, it's the meeting that John's going to come to, we are also pretty close to getting a Devon-wide CIC up and running, under which the primary care, the GP one, so it's primary care as the overarching, the GP CIC will sit below that. The reason they're going to be CICs by shares is so these can take primary care contracts in due course. And obviously it will talk at scale and represent the people of Devon at scale. The last thing is, Pete alluded to it, was the work, the clinical leadership group. It's becoming very apparent there are 5 big areas, and the big 5 seems somewhat appropriate, almost along the lines of a walking safari in Africa because of the jeopardy potential. They are surgical, maternity, peds, UEC and neighbourhoods. Our work on those will determine ultimately what the right size and shape of delivery of those specialties is across the Devon. I would actually like to move it from the big 5 to the 1+4 because neighbourhoods are the delivery model of the future. Neighbourhoods, a bit like safeguarding, is everybody's business. And we absolutely have to think neighbourhood first. So me, the determinant is if neighbourhoods are up and running properly, that's the good news story, and then you can look at the right sizing of all the other services of the big 5.
Okay, thank you. Let's move on to Phil.
Thank you, Chair. So I'll add my sincere thanks to Libby for the role that she played over the last period, and my warm welcome to Mark as well, even though he's not in the room. So Debbie and I are bringing forward a joint partner member paper this month, and that paper is about something called the South West Provider Collaborative. It was one of the first provider collaboratives in the country and sort of has its genesis of almost 10 years ago as part of Vanguard New Models approach. One of the reasons we thought it important to bring it here today was one of our learnings is despite the fact it's been around for 10 years and hugely successful, various versions of ICBs and CCGs haven't been as well informed about the work, and there are clear connections, obviously, to local pathways of care. So I just want to take a couple of minutes, if that's okay, Chair, just to lift a bit of detail up about what it is. So, as the paper says, it covers 4 tertiary care services in mental health. So it's adult secure services, medium and low secure, not high secure like Broadmoor would be. It covers CAMS Tier 4 services, adult eating disorders that are Tier 4 as well, and perinatal Tier 4 services. It covers the whole of the Southwest, so we're talking about 7 ICB footprints, and it's a population of around 5 million. We're talking about relatively low volume, but high complexity, high cost packages of care for a small part of our population across the Southwest. It has 6 NHS partner members and 1 CIC, which is Live Well Southwest. And one of the key bits about this is that it's been a full delegated responsibility from what was NHS England's responsibility for SpecCom mental health services to now double delegation through Somerset. But the whole point is it has been completely delegated as a responsibility. That means that we're responsible for the money and the quality oversight of the services as a collaborative. So it's about 170 million in terms of budget as well, so it's not small money either. And that's allowed effective pooling of money across the Southwest to think about how better to develop. So some of the key successes of this have been that people have received better care over a 10-year period as a result of the work of the collaborative. This is provider-led transformation, but commissioning informed by population need and really, really strong clinical support. So there are clinical senates that sit behind each of the service lines. There's really good, strong peer challenge within the collaborative as well, and this has been a left shift as well over the last 10 years, because one of the good things about having full delegated responsibility for budget is we've been able to reinvest as we've effectively brought patients back into the Southwest from private provision. We've been able to reinvest that money into community services. So whilst it's specialist services, it still is very, very aligned to and a good success around the left shift. So the work is ongoing, of course it is, it never stops. The current focus of transformation is on CAMS Tier 4 at the moment, and the transformation plan talks about effectively reprovisioning the Southwest away from general admission beds, which we have too many of, to more eating disordered eating type beds where we know that there's a massive issue for the population. So that's the next phase of the transformation, which is being entirely funded from within the existing resources because of the way that we've made improvements. So that's my sort of moment to pitch the collaborative, to hopefully just add a little bit more to what was in the paper and ask if there's any questions, Jay.
Any questions on that? No? Sounds like we're all on board. Very good. Thank you very much. Debbie's not here today, is she? I don't think. No, okay, fine. Stuart, good to see you on screen. Anything you would like to add from your seat?
I'm sorry, I've only just joined because I'm just coming in. Do you mean specific to this item?
No. Just from your seat.
My seat in the...
At the table. That's GP Collaborative Chair.
Have we done the... Sorry, I beg your pardon. Have we done the primary care update?
We have. I just want to give you the opportunity. Is there anything else you wanted to add?
Yeah, OK. So I did just want to comment on that, if that's OK, Chair. Yeah, Thank you. Apologies for disrupting the flow of the meeting. It was just on the emphasis on the advice and guidance piece. So that still is a very transactional model of outpatients, which we did raise concerns about today with Manal, that if that is mandated centrally, that we have to follow sort of lots of advice and guidance. It doesn't really help with our transformation of outpatients that we're planning in our neighbourhood model. And there's assurances from Manal that that is a sort of backstop, if you like, but if we can come up with funding flows that are what is best for our populations and our clinical services and our patients, that we are able to implement those locally rather than having to do this sort of advice and guidance pathway, which still feels very transactional, rather than transformative in the way that we are pursuing some outpatient.
Okay, all right. So on that basis, Chris, how can we help?
So what Stuart's saying is the advice and guidance sort of butts heads against what we want to do in terms of INTs and neighbourhood.
Exactly.
So I've made that quite aware to the national team, and I think what we're finding is we need to find a local solution, and I'm confident. Through the GP Collaborative and colleagues, we can find a local solution that allows us to keep going with the multidisciplinary team, the sort of specialist advice in INTs.
Is there a value in a letter from the board to somebody nationally?
I think we may have to go to that a bit, Chris. And that's certainly what I understand has happened elsewhere, according to Manal. Yeah.
Yeah. So that's why I think if you'd be happy, Stuart and Chris, to take it away. I mean, clearly just make sure Company Secretary's happy with all of that.
That'd be good. Yeah.
But Neil, you happy with that as an approach? Yeah.
Yeah, I really welcome that some action being taken on this, because it's so counterintuitive to what we're aiming to do.
So we'll empower you to make that. I'm glad I came to you, Stuart. Good. Thank you for that. Let's go to... I've lost my place. Let's go to Yunan. Anything else you want to add? I'm just checking there's anything else you wanted to add. I came to you earlier on, did I? Yeah, okay, fine. And Lincoln, I came to yourselves.
Yep, so just to say the contents are as read, and I encourage you to read the reports. Directors of Public Health have a responsibility to provide the board and the NHS with population health for your commissioning. And it's really moving the endorsement that we heard about having us at the table. Each of us provides an annual public health report. So there are 5 reports, and I've had some informal discussions with Neil about which committee structure we might go to have those fully aired, so that collectively we can act on the relevant recommendations for the NHS. And certainly, as in my report for Devon, as we land those, we will highlight them so that you have an opportunity to read and review. Thanks.
Okay. Thank you very much. Now, Emma's not here, but I understand there's an intriguing joint initiative here, which is lovely, Diana. So on behalf of maybe a bit of both, could you do? That'd be great. Thank you.
I certainly can. I'll do my best. I think really I just wanted to reference back to Manai's comments around the critical nature of the VCSE in delivering collective left shift aspirations. And of course, Emma and I colleagues between Devon and Cornwall are really, really keen that we share and learn best practice from each other. So yes, for the first time, we've managed to put together a joint report. We intend this to be the future moving forwards. And we've been doing a range of other pieces of joint working, which are still in their infancy, but we will be bringing those to the board in due course. I think the key point in terms of both Cornwall and Devon that we've raised is there were still some question marks around some of the funding issues, which we are both feeling as if we're having really good engagement with the respective executive teams. And so we're feeling that those issues are being discussed and resolved in a partnership approach, which is really helpful. The issue that I mentioned in the report just about the whole business about how we bring Devon to the place that Cornwall already are and how we're quite far behind. I just wanted again to acknowledge the investment within the sector that was agreed by the board in Devon and to assure the board that we are working at pace, very, very much at pace. And we have now got agreement across the Devon voluntary and community sector as to the approach we're going to be taking forwards in terms of our governance arrangements. And we expect that they will be confirmed in the next month or couple of months with the Charity Commission and so on. So that's all very much those foundations that need to happen in Devon that have already some while ago happened in Cornwall. So just to say we are catching up. It will take us a bit of time, but we are working at pace to try and achieve that.
Thank you. I don't know whether Emma's mentioned it to you, but at a recent regional NHS Southwest regional level, the chairs of the clusters and the chief execs got together with regional colleagues. There'll be certain things that we'll want to do generally at regional level in order to make sure the Southwest gets its voice nationally, to be fair. And one of the things that came out of that is that I asked Emma to actually chat to you, but also then to chat to Rachel about how maybe Emma might, on behalf of the Southwest, actually take an active role in putting together the VCSE element such that we understand how we can leverage best practice, not just in the Peninsula, but how we could help the other two clusters in the Southwest, or actually how much they've done things that we could learn from, and then also leverage anything nationally in terms of contracts or initiatives that are done by national charities that maybe we miss out on by being Peninsula. So if you could just take that away, I'd be very grateful. At the next board meeting, I'd like us to have an update on, is this something that is of interest to us and to region, and is any progress being made on it? I think it could be a really powerful movement for the voluntary sector in the Southwest and for us in the Peninsula.
Absolutely. And just to respond briefly, I think it is part of the success of Cornwall that Emma takes such a lead role at both national and regional level. And we are currently working to develop that further.
Very good.
So
if you could feedback next month, I'd be very grateful. Okay. I think that brings us to the end of the partner sides. We're going to move on to the non-execs side of things now. Now, in terms of audit and risk, because Lopa's on holiday, Martin, you're going to give us an oral update, please.
Yeah, brief update, John, if I may. So, first of all, just to point out, this is a truly peninsula-wide committee now, so well done to the execs for bringing that together, and the chair, because it's actually still a little bit clunky. You've got two sets of internal auditors, two sets of external auditors, but this meeting on internal audit reviews, the good news is, whilst both use slightly different language, the expectation and hope is that we will be given a sort of satisfactory level of assurance for our internal controls environment for the year that we're just closing across both historical ICBs, which is good news for the accounts. External audit, both planning for the year end appropriately, and whilst we've still got one or two year-end meetings in flux in the diary, we are content that the finance teams and the auditors are working together to provide us with coverage of the accounts at the year end. I think any specific issues, I think probably the only one that was highlighted was that we've received audits around data protection and cyber security, which continues to be a risk of everybody in the country, as it were. But specifically, we are still trying, I suppose, as a lot of people are, to work out how we get second-hand assurance, as it were, from people like commissioning support units, other organisations that provide services into the two ICBs.
that we aren't directly auditing ourselves, but as in previous years, I'm sure those things will come out in the wash. But I think that was probably the key issues raised, John.
Okay, thank you. Tan, could you give us an update from your seat, please?
Yeah, sure. In terms of people, obviously this is challenging times for our workforce. In terms of the ICB redesign, it's really challenging for our staff head to be going through another redesign. But we're getting there with it. We're starting to move now, and hopefully we'll have a new shape within the next few months for all of the staff. In terms of CIP across the whole system, we have some really significant challenges. And there's a lot of movement that needs to happen. And I am concerned about the exit run rate that we're coming through for the end of this year, going into the next year. Hopefully we'll talk a bit more about that later. We have to make sure that our CIP plans are grounded in reality. In terms of better news, in terms of customer experience, we've had some really exciting plans around the integrated neighbourhood teams that Lucy and her team have been driving forward, and look forward to seeing more in that space in the future. And we have started to look at equity and how we cross all of our different strategies and plans and make sure that we look at them through an equity lens. And I thought it was really telling today with the women's focused vignettes that we can look at some good practice, we can look at some difference in treatment and actually work together with all of our providers and with the councils in particular on how we join up and better produce equity of outcomes, moving from equality of opportunity into the third decade of the 21st century. There's some real basics here that we need to really move on, and look forward to working with you all on that space.
Okay, I'm sure we'll pick up some of those elements this afternoon. Thank you. Neil, yours is an oral update, so please go.
Thank you, Chair. The committee was only held last week, hence the oral update. The committee noted and approved the Neighbourhood Health Creation Engagement Plan and congratulated Lucy and her team on that. I think it's important to note that that's an engagement plan that's been brought together with many different partners, and that's the approach that will be taken. And it's a live and adaptive approach. It's not just something that's going to sit on a desk somewhere. It's something that will be worked on. And members agreed, both across Cornwall and Isles of Scilly and Devon, that ownership of engagement needed to deliver a community health and wellbeing approach at grassroots level as much as possible, and there were many examples given of that. I think it's important for context for members and attendees here to know that the committee currently has attendees from primary care, VCSE and public health in both Cornwall and Devon. And we received updates on the neighbourhood blueprint from Cornwall and the Devon system transformation plan. We listened to what was going on there, and we also took in context the new national framework document on neighbourhood health. And for anybody wanting to get an easy grip on that, the National Association of Primary Care have done a summary page on that is really worth looking at. So some key issues were discussed and developed out of those two main documents. And the first, linking to what Lincoln said earlier, was that population health needs to be understood and the work on that shared between ICB and public health colleagues in order that the ICB and health and wellbeing boards can align on the outcomes and objectives for neighbourhood health. And that's a very clear drive given to the committee. There's also a need, and we touched on this earlier in a number of different ways, we need a convened subgroup meeting to develop light touch enabling governance around the neighbourhood space. And that should allow the necessary devolution to place that's been alluded to in this board meeting already. The Cornwall Plan has developed a proposal around a framework, and the ICB needs to look at this, reflect on Devon's input, and align proposals with the Neighbourhood Committee and other committees as appropriate. But the aim is that it's light touch and it allows a devolution of decision making and hopefully eventually budgets. I just wanted to put across that the members and attendees all challenge the committee, as in what is stopping us moving at pace in this area of neighbourhood development. And an underlying concern came throughout the meeting that there is a risk, whilst we understand that hopefully this can be mitigated, that the system financial issues in Devon might impinge on the proposed investment in neighbourhood development. The worry about that is GP and VCSE working hard with goodwill, and if that proposed investment was to be withdrawn, I think it would be a really bad thing. But I think it's best to be honest and say that came up at the committee. Thank you.
Okay. Thank you very much. So we've got the Finance, Performance and Quality Committee. Devon first.
Right, thank you very much. So in the papers there are two meetings that are reported upon, 12th of February and then the 12th of March. The 12th of March one, however, landed just ahead of the plan submission, which caused a lot of effort to be diverted away from the committee. So there were a couple of things that we'll be bringing back in due course to that committee. But if you don't mind, Chair, I will spend just a few minutes on some of the topics that we've covered in those two meetings, as I think they're quite important. So in terms of the finance position, although it seems an awfully long time ago, month 9, was where we formally, through a process that was defined for us, agreed to change in our forecast. And so it was that point that we formally recognised the change position of RDOH and the loss of deficit support funding. And the consequences of that, of course, then ripple into the new financial year. The changes themselves were approved, and we've all been very keen that we don't move further from that position. I'm pleased to say that at the subsequent meeting, we are now on track to deliver our approved forecast position, albeit it's not where we would like to be. That said, as I think I have already highlighted, the mixture of recurring versus non-recurring SIPs is different from that from plan. One of the things that we look at is the underlying position, and the difference between the underlying and the actual is that the actual may include one-offs, which you can't assume will therefore continue into the next year. So the consequence of a higher than planned non-recurrent is almost by definition you're not going to see those savings the following year, means that the consequence is that whilst we have a defined deficit position, the mixture means we will go into the new financial year at a higher underlying deficit position. But that said, we have some time ago reached a position where we've viewed the ICB, the NHS Devon's position, as assured, and it has been fairly consistently on plan for a modest surplus, and that continues to be the case. When we turn to the One Devon position, the entire position for the system, as I've already said, that has jumped in month 9, but we are satisfactorily assured around the delivery of that element. Our assurance isn't given on one point alone. There are a number of things that we consider. And some time back, as I have previously reported, we realised that we could not be assured on elements of the delivery of the entire system plan. Turning those to other domains, which are also, of course, important for this committee, we look at quality, and there are typically a division between a really detailed report and a higher level report, and then we have some deep dives. So I was interested in the women's health, for example. It's one of the areas we do look at. We look at patient safety, we look at patient engagement, we look at mental health. There are a number of domains in the quality that we receive reports on, and I'm pleased to say that in overall terms we are content with the position in terms of quality. In terms of the performance, I think we all know around this table and the virtual links that our performance overall is not where we want it to be. There are some areas that have been and remain highly intractable, and one of the things that I have suggested that we should do is that in the contract reviews that we look at, as the year end is approaching, we would like to look back for learning purposes, not to become a witch hunt, in terms of what assurance were we given, what actions did we see were being proposed, and have they actually delivered those changes or not? Because it's certainly the case that some of these intractable problems have had actions against them, but we still see that performance is not universally where we would like it to be. That said, we're not saying that everything is bad. In fact, we looked at primary care in our last meeting, and as I think some of our colleagues have already highlighted, there are some areas of excellence in our primary care, not being complacent about it and minimising the challenges. We also looked not quite to the depth we would like to at our last committee meeting in a particular area, which was the local maternity and neonatal services. As we all know, that is a subject of national interest politically and media-wise, with a newly appointed Ockenden piece of work to be done there. So we have looked at the services in Devon. We were assured to an acceptable level in that meeting, but as already highlighted, because of the time pressures, we will bring that back for further scrutiny in due course. We're also aware, finally, that there are some cash pressures in the system as year end is approaching, and we will be looking at the ability to cover that as obviously the lack of deficit support is impacting upon that. But with that, I will stop and I'll open it up for any questions. Thank you.
Any questions? No? Thank you. Martin?
Thanks, John. Similarly, 2 meetings, one of which is in the pack. I suppose the summary or things to escalate from the one in the pack particularly. I think you've already mentioned Kono CIC contracts, which we acknowledged needed to go up the line to the board to be approved, which it has been through you and subsequently today by the board. We talked a little bit about mental health out-of-area placements and some changes in the commissioning for that to try and reduce out-of-area placements, which has now been progressed through the commissioning route. Still to be finalised completely as I understand it, but it's more or less there. Probably importantly to note that we reviewed the arrangements for safeguarding adults and safeguarding children partnership, the annual reports thereof, and we're happy to sort of assure the board that we'd met our legal duties in both cases. So important to note that, I think. On the finances, both meetings are sort of following the trajectory to a break-even year end, notwithstanding that, as Graham has said, and Tan actually, there are some gaps in recurrent delivery of CIPs, but, the overall plan still being delivered at certainly break-even point, we hope, and seems to still be the case. I think the only things from the second meeting I'd bring up are, we also looked at the Green Delivery Plan, which is going to come to the board, and obviously discussed quite a lot about contract finalisation and the things that are going through towards the year end as we speak.
Thank you. Any questions? Yep, Neil?
Just a bit of information on the back of that FP&Q meeting. I asked a question about the utilisation of the virtual ward under the IPR. I've had that fed back to me, and it was really pleasing to see the numbers are around 120, and that the percentage, there's been a big percentage increase in the numbers being used, the virtual ward being used via the acute hospital. I think it's 44% now, which was really pleasing to see. So it's a big spread across all users of the virtual ward now, rather than just from the community in.
Okay. Mark?
Thank you for the feedback. I think one of the things I just want to emphasise that we've got a collective challenge on, and it links back to how do we generate the resources to do some of the things around prevention, early intervention, and investing jointly as commissioners in those type of issues that we talked about around dampness affecting respiratory health and so forth, is unless we grip this year the recurrent savings going into 27-28, what we end up doing is spending our growth allocations on further investments in our secondary care sector, and it crowds out all of the discussions we've had this morning. It crowds out the investment we need to make those shifts that we're all talking about, that we know we've got to make. Yeah, and so one of the things we will be focused on very much, John, is looking at how going into 27-28 we've got an exit position which enables us to actually create the headroom to invest in the alternatives we know we've got to make in our system. And within the year, we've got to look at how we've allocated some of our growth allocations. And actually, I've had a super response from my chief exec colleagues around this in Devon. I'm sure Steve is very supportive of this. We've got to look at how we use our growth allocations to make some of those changes this year. Now, for partners, some of that will have to be based around trying to address some of the fundamental demand issues, and we're trying to get some more headroom. But I think unless we get that and change that mindset as a system, we're going to really, really struggle, because we don't generate the resources we will get mopped up in further demand that goes into secondary care. So the kind of numbers go, secondary care investment has grown 40% in the last 10 years. Community has fallen by about 10. Yeah, and primary care even more. So we need to look at collectively having an effort to address that this year.
Okay, Steve, and then you.
Yeah, I certainly support the approach you outlined, Mark. One of the things I've struggled with a bit, John, and I think it's just by virtue of the two systems still being separate systems, is having enough of an understanding about where the mechanisms underway within Devon, and that might well be the case for colleagues in Devon looking into Cornwall and Isles of Scilly. But CFT undertook a comprehensive reconfiguration about 12 months ago. Some very, very difficult decisions undertaken to take forward consultations to reduce workforce to be able to, as efficiently as possible, deliver their services. RCHT have undertaken significant consultations and restructures this year, and one which is going to move into next year due to some issues working with union colleagues. And I think the Cornwall and Isles of Scilly Finance and Performance Committee has got significant oversight of that, and I'm sure, Graham, that the Devon Committee has oversight of what's happening within Devon. It's how we join that up so that we can see if there are things happening in Devon that are not being undertaken within Cornwall. We absolutely want to know that so we can drive that forward, and if there's any sharing that...
One of the huge advantages of having an aligned cluster management executive team from the 1st of April will be to exactly, I hope, bring the best of everything and level up as opposed to level things down. So I'm looking forward to the 1st of April.
So really welcome what you said, Mark, about the money and the finance, but there is stuff that we can be doing in prevention. So it's actually primary, secondary and tertiary prevention. Realistically, from COVID, I don't think that the systems are running as well as they could. There's the whole evidence-based prevention at all aspects in primary and secondary care that can be there. Right care, it's all sitting, it was all shelved. It's there to go again. I think that we need to actually look at whole-scale systemic look at quality improvement services, using the data to drive evidence-based intervention for... So while we're talking about the wider determinants, actually our clinicians, and we were doing this in Cornwall with the CRGs and stuff, is actually getting them around the table to understand the best evidence of the patients in front of them, what they should be doing, looking at system improvement and performance of areas that are working well to helping in the other areas. And if we can get the machine, I don't think the machine's firing in the way it could do, without actually spending more money at that, doing what we know works, and actually helping shape how our clinicians treat effectively the patients in front of them, and actually identifying areas of good and poor performance and using those objective ways, we could start doing that. And I think it's worth investing in that. And that is a more cost-neutral way of seeing some of the benefits, so that we can actually then understand where the true inequalities are, because it's about the inequality in delivery of care as well as the outcomes. We focus on the outcomes. We need to do more of looking at what people are actually inputting and doing as well.
I would agree.
Again, I'm hoping that the new structure that's going to be put in place will have the right competency at the right level to build and leverage that. That's a great point, you know. Anything else that people would like from this section? Okay, so we have a choice. It's coming up, let's assume it's 12:15. We can either take one more item. Mark, I'll look to you to see whether you want to do this, to take the staff survey this side of lunch, or whether you would like an early lunch. What would you prefer? Can we do one more?
Yeah.
Yeah, let's do one more. So let's move to the item on the NHS staff survey, please, Mark and Patrick.
Yeah, I'll introduce this really briefly. I mean, we've done the staff survey across. Sorry, I'll introduce this item briefly. The staff survey has been done across Devon and Cornwall ICBs, and the analysis reflects that. I think what it shows is we've got a lot to do in terms of improving our staff's views about the organisation, and I think with a single executive team and a single board, I think it enables us to a board that will move to a single board in 2027. I think what we've got is the opportunity really to start to forge a different sense of purpose and values within the ICB, and to move forward in a more energetic way, I think, around what we do to improve staff experience at work, and particularly their involvement and engagement, but also the investment in them as people associated with moving to our strategic commissioning role, which is quite a sea change actually in expectations for us. So, Patrick, can I hand over to you to go through draw out some of the specific. Maybe some of the good areas, some of the areas we want to focus on. Particularly we want to do around improving the situation.
Yeah, by all means. Yeah, thanks. So I'll draw out a few things from the report and a bit of context. So firstly, as is evident from the report, the results are pretty sobering. If we look at the percentages of key indicators relating to engagement or advocacy. I'll come on to that in a second. So very important, it's got board coverage today. Little bit of context. So participation in the staff survey isn't mandatory for ICBs, and it's important to note nationally that 23 of the 42 ICBs participated in 2025, so a lot chose not to. We made a deliberate decision last summer that we would, for two reasons. One, in a very difficult year, we didn't want to be trying to explain why we wouldn't participate in the survey. It's important that we know where we are, whatever the circumstances. And the second was we knew that we would reach this point, which is on the cusp of clustering and moving ahead for merger. So we wanted to establish a baseline of where we stood from a staff engagement perspective. A couple of other bits of context. In both Cornwall and Devon, the participation in the survey has dropped by about 10%. 62% of staff responded to the survey, but in the previous year that had been 71%. So it's a smaller sample. And the other part of context is the timing. The survey took place in both organisations in October 2025, which was 6 months after the national announcements about headline announcements of 50% reductions in ICB resources, and before the national position relating to redundancy funding had been confirmed. So people had a prolonged period of uncertainty, and we weren't even able to press ahead with the plans that we've done since then. So put yourself in the shoes of an ICB employee who became an ICB employee having moved across from the former CCGs, and in 2023 went through an organisational change that sought to achieve 30% reductions, and then in 2025 went through a change that took a further 50% out of that. So this is just important context for where people are as they are thinking about their experience of working lives in the ICBs. And I just want to call out a couple of indicators. There's many that we could dwell on, but in view of time, these are maybe the leading indicators. So one is about would I advocate working in the ICB to a friend, and that's the advocacy score. In Devon, that's 17% of respondents. In Cornwall, it's 32%. And what picking that particular stat is that nationally, the positive response rate to that question has halved since 2021, and both ICBs have followed a similar trajectory. Their relative positions are slightly different, but the overall trend is clear. And then, so that's a percentage. The way the survey works, it aggregates up overall engagement scores, so a score out of 10. Cornwall's overall engagement, 6% 6 out of 10, 6%, down from 6.8. Devon's overall 5.7, down from 7 in 2021. That's a score out of 10. So very middling results in relation to those. So I think another way of looking at the results is, and flipping this round, is what people are asking for. And what the report pulls out is there's a few things that we want to create as we move into cluster and merger that would contribute to turning the results round. So people are looking for trust, they're looking for clarity and stability in their organisational environment. There's quite a lot around capability and learning, and we know that in our new functional form, we've got new areas to improve our capability on: strategic commissioning, population health management, the whole area of digital, lots of things that we need to invest in from a learning perspective that would respond to that. People are also looking for help with workload, and with the scale of resources that will be leaving the organisations shortly, that's going to be a key feature of our transition, is how as a new exec team and how as a board we prioritise the resources that we have that helps staff's position on that. And they're looking for connection and belonging, and Mark referred to the energy that we're going to need to bring as a new exec and a new leadership team to comms and engagement, and making sure people understand what we're trying to achieve as an organisation and their contribution to that. So where that starts is where we are right now, is still working through the restructure. This week, 200 voluntary redundancy applications are being considered through our panels, and the results of that will become known in the next couple of weeks, and we'll be letting people know those outcomes. Also this week, we've been holding interviews for the next tier of senior leaders in the organisation. So those people will know their outcomes, and then the successful candidates would be forming the new director team underneath the exec group, and that group are going to be the ones who take forward the work we have to do to turn the results round. But what we will be doing, and have already started scoping and thinking about, is the OD work that would include our development as a board, the development of the exec team and the extended leadership team, and the capability building that we've described for the wider organisation. So we'll see a coming out of restructure in Q1, and coming up with our approach to stabilising the organisation first, and making sure we're connected and pulling in the right direction.
Thank you. It would be helpful to understand the Cornwall section is narrative with very little data, and then Devon actually has stuff to actually, so I can't actually take any assurances to take the same interpretations that are being presented, because the numbers, I can interpret those. It'd be good to understand that. And then I'm a bit concerned in line number 45 with Cornwall being the worst performing ICB for learning development for 2 consecutive years. Considering it's quite difficult to attract talent down to Cornwall and out of Scilly, that's also a concern that for the second years, what sort of plans are going to be in place to address that? Because how are we going to either develop talent or attract talent down if we're the worst performing and develop that reputation in Cornwall?
Good challenge. Do you want to respond to that?
I note the comments regarding data. There is a link in the report to the full data reports. We didn't want to bring all of it here. There's an awful lot of data analysis, but it is there and available for both. If there are specific questions to pull out, we could maybe follow that up.
Pick up afterwards with you.
Very happy to do
Very
that.
happy to. Thank you.
Sorry, the second point was around learning and capability and how we're going to build that, and that's the key thing. We have to turn that reputation around, and we'll have to be making investments as an organisation to support it. We need it for staff survey reasons, that investment. We also need it for business effectiveness, because we're going to have to learn how to operate in a new way. And unless we tackle that, we're not going to be a successful ICB.
So one of the challenges, let me just state the obvious. There was the CCG move into ICB, change 1 for our staff. There was the 30% reduction 18 months ago. There's been this extra 34% we've got to take now, and let's not lose sight of the fact there'll be potential implications at merger point. We're talking about restructuring 4 times every 18 months. That's a very difficult journey for staff to get into. So I think communication, sharing, building, investing, etc., is got to be at the heart of the next phase. Graham?
Thank you. Can I just try and bridge this to impact? And I accept this isn't a one-to-one relationship. But FBQ, we track the delivery of the annual plan objectives under 6 headings. So I won't read them all through, but first one, long-term whole population health care strategy. Another one, drive clinical service transformation, etc. There's 6 of them, and there's elements within that. And what we've seen as a committee is us going off track, so that on 2 of the key ones, the clinical service transformation, 6 out of 13 have been missed. And on the workforce digital piece, 8 out of 17 of them have been missed. And I think we can't do the full variance analysis, as it were, as to how much of that was things that we could never have done. They were too hard and difficult, or we were over-ambitious about capacity versus the requirements. But I think what we've been seeing is a manifestation of the things that we see in the survey in terms of the delivery of the ICB as an organisation. Certainly in Devon, I can't talk to Cornwall. So.
Okay, thank you. Steve?
Mindful, Patrick, this report is about ICB staff in Devon and Cornwall ICBs, quite rightly. I'm also mindful that, my understanding that I think almost all NHS providers in Cornwall and Devon have experienced some aspects of these changes and deteriorations. So the report refers to a decline in confidence in raising concerns as an example. And it refers to, as you've mentioned, the decline in recommendations of the organisation as a place to work. But that's certainly reflected very, very strongly in Royal Cornwall Hospital's staff survey results as well. And the reason for raising that is, what of this do we address within each individual organisation, and what of this can we do either collectively or in a way that reinforces the actions that individual organisations are taking? So particularly that point about raising concerns, I'm sure every one of us around this table would want any staff in the NHS, wherever they work, to feel open, supported, safe, to raise concerns immediately, and to have the freedom to speak up confidential mechanisms as a fallback protection, but to do everything we can. So I just wonder if there's anything more we can do, Patrick, collectively across the whole of the NHS system to have an even greater impact collectively, as well as the work individual organisations will do.
Yeah, thanks. I think that's a real opportunity for us forming as a peninsula to identify areas which we might have in common Like you say, Steve, we wouldn't want to interfere with organisational responsibilities, but if there's value we can add by taking a peninsula-wide view, then that is definitely something for us to follow up. And it plays to Eunan's point. We might have particular issues that play across our peninsula from a labour market perspective where collaboration would be good. And being able to send positive signals about what it means to work in the variety of institutions, sectors that we represent across both Devon and Cornwall would be a really positive place to get to.
Okay, thank you. We're going to go Lincoln, Chris, Neil.
Thanks. Really sobering report. One would hope that nationally they're looking at this because it's not just the CCG into. My experience is about every 2 years we create this uncertainty for staff, and it is testimony that staff continue to deliver in the face of all of that psychological unsafety. A couple of things in terms of the reputation of the NHS as an employer of choice and the statistics about the numbers who are looking to leave, the numbers who are not recommending. Torbay, the Trust, is our largest employer. You know, this is opportunities for young people, not just in medical careers, but the whole of the NHS. And if you think about what this percolates into a population that doesn't have that many choices, you know, this is damaging on a much bigger scale. One positive I saw in this was Devon's statistics around inclusion and diversity and so forth. And I remember when I joined, it was one of the things that it was just on the end of the Black Lives Matter. There was a specific report, which I think there was bravery in Devon in commissioning that report, in listening to people from diverse backgrounds and in taking action. And I think it's some legacy of that work and suggests that we continue to keep that on the radar and continue to build on that success and indeed see how some of that learning might apply in Cornwall. Thanks.
Okay, thank you. Chris.
Yeah, I just want to, in our 8 outcomes that we want to look at neighbourhood, specifically one of them is about a happy, resilient workforce for the very reasons I think we've articulated. And then in point to Steve's question, I think the way we help is not just the OD for the ICB. I think that the way we build our resilient, happy workforce is actually taking a more system approach. And we've already started doing that with RCHT colleagues, so we're planning, because of the divisional restructure, we're going to do 4 clinical summits, which I think is a really way of empowering the workforce. And I'd like to do the same for Devon, because that really starts to get that sense of purpose, autonomy and mastery. Yeah.
I want to make a couple of comments. Patrick, do you want to come in now or do you want to wrap us up?
I'll wrap us up.
Shall I go next then?
Please, yeah.
Love it, okay. I think this is a huge opportunity for us to do what we'll call a reset of everywhere, coming together with the new executive teams, the rolling out of the new structures and that kind of thing, to genuinely work towards almost what is going to be April 27, such that it doesn't become a cliff edge in 2027, and recognising we have 2 sovereign boards at the moment, but we should act as if we were one entity as we go forward. And one other challenge, I still think ourselves and our staff think that we're being asked to do everything we did before in exactly the same way, but with just less staff. There's probably a lot that we're being asked to do that's probably pretty similar, but it's down to us to work out what are things that don't add value that we can stop doing in order to actually release our time and energies for staff to actually concentrate on the things that shift the dial. So when I raised this with our regional colleagues, mentioned earlier on, I met with the chairs and chief execs at a regional meeting last week or week before, and I made the point about stuff that comes down from the national team and the regional team that we just have to do because we're told to do it. And the challenge back was, well, tell us what you want to do differently. We need the same answer, but if you want to give us something which is less bureaucratic, less intensive, but gives us the same outcome, then come back to us and challenge it. So I think as we enter this next phase, we not only just need to empower staff to do what's in the frame, but actually challenge the frame as well and come back and go, how do we be more effective in what we do? And I think that can be quite liberating for people to actually feel they can own it, change it. So I'm throwing down the gauntlet. If you want to think about, as an executive group, what it is that, I'm not sure you'll take it through the executive group anyway, Mark, but what is it that we want to do as a board that challenges regional and national team to do things simpler, with less bureaucracy, but to the same outcome would be really helpful. All right. You wrap us up, please.
Yeah, so firstly, just in response to that point, I think that's a really positive invitation to give to our workforce to say we can challenge to challenge that. The other positive that I just wanted to highlight was we have to act, and we have to act with urgency because the results tell us we have to. There's also a 2040 opportunity at the other end of this, and it's just something to highlight that we've taken through the People Committee recently the draft research we've been doing around forming a 2040 workforce strategy for the Peninsula. Cornwall's been doing some work using 2040 as its frame. Devon has been doing work using 2035. We'll be bringing that together. It starts to create a different ambition, picking up that earlier part of the conversation. So the time horizon is urgent action needed, which we will do as a leadership team, but there's a longer term piece as well that is a really good vehicle for engaging people to think differently.
Yeah. One other thought, building on something that you mentioned earlier on, I think it says in the paper that the survey results, or the survey ended in early October. Is that right?
Yeah, that's when it was undertaken, yeah.
Okay,
yeah.
right. The reason why I say that is, of course, I remember the date specifically. I was in London at the time. The 13th of March 2025, of course, was when the announcement took place about more clustering.
Correct.
Bringing people from 42 into 26 ICBs. So we only started as a cluster on the 1st of September. I wonder how much of these results has been the legacy of the announcement from middle of March last year that's actually being increasingly embedded in our thinking, hence why we need the reset. So I think this is as much a legacy of a long period of time rather than just an immediate reaction to the clustering.
Yeah, I agree. And the challenge is that the next survey will be undertaken in October. Yeah. One other thing to add is that something that Devon do really well is not rely on the annual survey, and we need to replicate this in Cornwall, is using pulse surveys to keep a regular track on how we're doing. Not just wait annually to see what's happening.
Very good. Okay, so trying to draw us to a conclusion, if that's all right with everyone. Yeah. Okay, so let's look at the recommendations. So I think we've reviewed the results well together. Consider the results for both organisations through the lens of prolonged system change. Do you think we've dealt with that to your satisfaction, Patrick? Yeah. You're looking for support, Chief People Officer, which is going to be yourself from the 1st of April, with the OD programme. I don't think anyone's going to disagree with that. I think everyone's going to ask just one key, well, I certainly asked the key question. The staff presentation yesterday actually talked about not concluding a lot of this until June. It's still March. That's going to leave a difficult window to start rebuilding a reset until people know what they've got. So if there's any way in which you could think about how and when the reset will actually start to really gain momentum, because I'm struggling to see how, for the vast majority of our staff, they can feel confident about the future until they know whether they've got a role or not. Yeah. But I think everyone is supporting your direction of travel, and the plan is as indicated. I'm going to take that as everyone's happy with that. Yeah, I'm not going to read it all out. And agree that the results serve as a baseline. Yeah, I won't read it all out. The development of the delivery of the OD plan improvement. When do you think you will bring back a more granular OD programme for the board to see?
Probably around May, John. We're going to talk. I mean, we need to engage. We need to engage the staff in actually discussing it. Yeah. We've got to look at that as a team, really. So I think May is probably
at the earliest,
realistic,
probably.
Really.
Yeah. And I think you need to take quality time to land this correctly. Everybody happy with that? Okay. Lovely. Well, let's move on from there. So it's now, let's say it's past. Are you happy to come back at 1:05? And we'll start, but can we start promptly at 1:05? And then, because there's quite a lot of agenda items this afternoon that probably haven't been given enough time in the agenda window. So we start at 1:05, we'll give ourselves a bit more time. Okay, let's break there. See you at 1:05. Thank you very much. hope you had more than a Twix, which is what I had. So I think you've joined me in a bag of crisps, is that right?
Not had any yet.
Would you like to go and get some crisps? No, knock yourself out.
Wait till
That's fine. Okay, Libby, we're in your hands. The commissioning plan, please, for NHS Devon.
Lovely. Thank you, Chair. So obviously the full documents are in the paper, but just wanted to pull out a few key messages for the board today. So this commissioning plan being presented is a key step forward for NHS Devon in its journey to deliver the health and care strategy that the board approved in October last year. There's significant work underway to translate this into detailed plans and looking forward to commission sustainable services for the future. Obviously, this plan has been developed in the context of the performance and financial challenges that we have in Devon, that this board is well cited on, and promotes a commissioning approach that will see the movement of care into neighbourhoods to wrap around services closer to home wherever possible, and obviously really embraces what we've heard today as a board in the earlier presentation. Recognising also, though, that transformation is also required of our specialist services to ensure the sustainability long-term and delivery of high-quality, effective care at that specialist level when people need it within our communities. So the commissioning plan sets out why the change is needed, and you'll recall that the board received a detailed Discover diagnostic piece ahead of the health and care strategy that set out the real challenges in Devon, but more importantly, the real opportunities based on the available evidence that was reviewed as part of the strategy development. The commissioning intentions, therefore, begin to set out the actions that we need to take as a commissioner and as a whole system, and the commissioning expectations that we will have of our NHS partners and providers as we move forward in delivering services to the population over the next 5 years. So obviously there is some key work underway and needs to continue around the key enablers that underpin this plan, and we've already touched today as a board on workforce as a key enabler, and also recognising the need to really embrace that analogue to digital shift as well. As well as direct commissioning actions, as I said, as a system, we've been working really closely with our provider, chief executives and executive teams to set out a transformation plan with system ownership to look at across the whole of Devon how services can be best delivered, making best value of the resources that we've got, but also as moving into being a strategic commissioner, very much focused on the health outcomes for the population based on the evidence. So the other area I just wanted to draw the board's attention to today is that you will obviously be aware of the work that has been underway on a cardiology case for change since the board's decision to not proceed with the PPCI test and learn. And over the past year, we've seen some real improvements in the work that we've been doing on access, performance and prevention. And with the development of our strategy in this 5-year commissioning plan, it gives us an opportunity to look at cardiovascular health more holistically as part of the future commissioning of our health outcomes and services. And therefore, as part of this paper today, I'm proposing to the board that we won't proceed with a separate cardiology case for change, but we will incorporate cardiovascular health, cardiology within the broader engagement on our commissioning plan with our customers and local population. So it's really important for today for the board to recognise that is a really important step forward for us starting to have a conversation with our public and stakeholders about how we bring this commissioning plan to life and deliver the outcomes that our population deserve. So those are the key areas, Chair, that I'd like to pull out today.
Excellent, thank you very much. So other than that, take the paper as read. Any questions for Libby? Yes, Phil.
This bit of a boring, basic one, Libby. I mean, there's a lot, isn't there? There's a lot to do. Just getting a sense from you about the capacity and the timelines of delivery, how confident you are that we're going to be able to do all of this in the time frame necessary.
Yeah, so I think that's a really important challenge for us as a board, isn't it? Because we've already heard today that we are going through quite a significant restructuring. We've got the opportunity of the new executive team coming together to deliver this. The importance of it being a 5-year plan is that we can clearly articulate the real key priority areas for year one, so that we can identify and move forward where there are quick wins and areas that we can improve more rapidly. But the importance, I think, for Devon going forward, which is why this longer term planning horizon is really important, is that stability and delivery of services needs a longer period of time to really think about how we transform that. So I think it's the balance between the immediate priorities that we know we need to address as commissioners and with our providers and partners, while we build the foundation for that medium to long-term transformation that we need to.
Okay with that? So we'll go Sam, Mary, Steve. Sam?
Yeah, Libby, I think, welcome the document. I just wonder whether we need to be a bit blunter, if we're thinking about the conversation we've had this morning about the need to shift investment into neighbourhoods. Mm-hmm. The consequence of that is all of our hospitals will be smaller. And I just wonder whether we need to be more explicit with the public that is the case. That's not a bad thing, but that's the result.
Yeah, so I absolutely agree, Sam. And actually, we had a really productive conversation with Health Watch this week about the need to have, a really honest, transparent conversation with our public about the real challenges that the NHS faces locally, and therefore the importance of having that level of engagement. And as you can see from the paper, we will be starting that engagement with the public immediately after this board with the support of Health Watch, because I think that conversation is going to be absolutely key in making the changes that we need to make over the coming years. So absolutely agree, Sam.
And Sam, I was part of that conversation with Libby and Health Watch, and one of the things that for me that came out of it is that and I'm sort of quite an advocate of this generally, which is we're very good at articulating in silo what it is with the acute or not the acute or whatever. But our patients and our citizens quite respect the idea of what's the total service offer, whether it be general practice, primary care, secondary care, the wraparound services that we've actually got. And we've got to get slightly better at articulating what the total service offer is, rather than just this is a hospital or not a hospital implications in our commissioning intentions. So we're going to go Mary next, Steve and Frank.
Thank you. Libby, obviously we've got the CDC 1 coming online later on in the summer, so it's just really, I'm presuming you're having good conversations with them so that they can come back to scrutiny and sort of say that and whatever, because I think that'd be really essential, because we know that a lot of the people down in that west end of Plymouth aren't particularly brilliant at going out to Derriford. I'm sure Derriford would be quite happy to have less people going out there. So it's a good opportunity, isn't it?
Thank you. Steve?
Yeah, echo the comments that have been made so far, Libby. I welcome the document. I think it sets out the intent really well. Mindful it's a Devon document, some of the aspects within here would potentially have implications, benefits, other implications from a Cornwall and Isles of Scilly perspective. So as an example, the transformation of cardiology and cardiovascular services within Devon would I assume, have consequences, impacts, opportunities, risks and benefits for Cornwall and Isles of Scilly patients and residents. So it's really how we have that peninsula-wide view to ensure that any actions you need from Cornwall and Isles of Scilly partners are engaged, but also if there are implications on patients and communities across Cornwall and the Isles of Scilly, we recognise that in the strategy going forward.
Do you want to respond to that?
Yeah, so yeah, absolutely. And just to provide some reassurance to the board that although the the national planning framework means that while we cluster, we have to have two separate plans. We've been working really closely across the two ICBs during this planning round to be really cognizant of where there are impacts. And I think what we'll see as we come through into more of the delivery plans that becomes more apparent. And obviously, as the Chair mentioned at the outset, we have a new Peninsula cluster exec from next week. And so part of the work over the next 12 months is going to be bringing the strategies and the commissioning plans and the transformation together as a peninsula, because there are huge opportunities there, aren't there, Steve? So, yeah.
Thank you, Libby. Thank you. Frank?
So I'm sort of in agreement with Sam that we have to possibly be more open with the public, but the openness I'd like is that we have to live within our means. But I think we can sell a positive story, and that's what we need to do. The neighbourhoods, why I said it's everyone's business, is because the neighbourhoods are the delivery model of the future. And profit-driven organisations in America choose this because it's the most efficient delivery model. So what we've got to do is absolutely deliver and aim for excellence in the neighbourhoods, and then the consequence is there will be a change in the hospitals, but it's not starting from the change in the hospitals as far as the public is concerned, because of course they're going to resist that. What it is about is giving them a good news and actually delivering stuff in the community.
Okay, thank you. Neil?
Couldn't say it better than Frank. That's what I was going to say.
Gosh. Excellent. Any other comments? No? Okay, so...
Yes. I think I agree with Frank, but I think it's important that we're clear and explicit as well, that in some instances, the level, the nature, the absolute challenge that we're facing, to me, looks like some services will need to be delivered. That might require patients to travel further on the basis that that's safe and that's the most efficient and effective way of delivering it. So I do think, Frank, we need to be clear about the benefits, and that's what drives this. But I also think what Sam was, not to put words in Sam's mouth, but what I was hearing from Sam is we need to be really clear and open about those other impacts as well, and be as transparent as we possibly can about the scale of the change, the scale of the transformation, and recognise that in some instances will have impacts in terms of access challenges, needing to bring services together in some instances, because that is the best way to support the needs across the peninsula. So it's just try to have that clarity and transparency, I think, would be important.
Okay.
Well, I mean, let's absolutely reflect that, because that is absolutely right, and I think. You know, we need to be aiming for excellence, don't we, Steve? And I think that is actually absolutely right. The other thing for me, Chair, is how are we going to measure whether we're successful in this, Libby?
So I think this is very much about the new blueprint, isn't it, as the strategic commissioner, because it's that shift towards population health outcomes from what we're commissioning as commissioners. So we need to be really explicit in our contracts with our providers of what we're expecting as outcomes, not just activity. So I think there's a lot of work to do. You know, we're on a journey with that, and we're going through a significant change as an organisation at the moment, aren't we? But that's going to be our mechanism as a strategic provider to ensure that ultimately how we spend the public pound on services and prevention is going to get the outcomes that we want to address the inequalities that we see in our population at the moment. So I think the mechanisms are there. We just need to make that, to strengthen that.
Well, maybe one suggestion is based on the maybe one suggestion based on the I'll get used to turning the microphone on in a minute. Maybe one suggestion is that for each of the priorities we look at what are the critical success factors and what are the and we get some outcome measures associated with that. So around the table we're all, when we review this plan during the year, we're clear what we're achieving and what we may not be. Yeah. I'd like to have something simple like that, so that actually everybody sort of feels good, because I'm sure we'll make a lot of progress. But it does feel important that.
I strongly support that, Mark. I'd certainly lend my support to that. I don't know if this is possible, but public satisfaction as an overarching kind of measure, because we don't have that information at the board, and it might not be feasible to achieve it. But if you step back from this, that to me would feel like one of the mechanisms about is this successful would be what are the communities across Cornwall and Isles of Scilly and Devon say, and is that measure of public satisfaction in the NHS? Is there a way of harnessing that? So it might be. Might not be possible, but
it almost certainly is possible, actually. The only other observation I'd like to make, based on Mark's observations, is that there is something about taking the direction of travel of some of these issues and having trajectory points in terms of what does it look like, when will it be alive, and measuring our expectation of getting there. Because if not, it always feels like it's just over the horizon. So I think it's how we now take these pieces of work and we start to land them in the how and by when. Martin and then Una.
So, John, I think it's fair to say that, I mean, Libby and I have talked about this. We're going to sort of make sure that with these intentions, we're really clear about translating the intentions and the plan into what are we going to deliver, how are we going to measure it, what's the timeline, who's doing what. How we co-produce and co-design with our partners, for example, and how do we monitor and evaluate with our partners? Because I think actually out there, outside this boardroom, there are 30 or 40,000 people who work in the health service. There's a lot of people who could give us, actually help us with the evaluation and monitoring of these things if we break it down properly.
Very good. Okay, so Martin and Una. Yeah, Martin.
Yeah, I guess just following on from that, I'm the first one to try and have trajectories, deliverables, and hard measurable metrics. But I did want to make a softer point, which is that we did previously have very much a convening role as an ICS and early ICBs. Now we're moving more into historical style contracting, which is great, and this is a commissioning plan of the ICB. But I didn't want to lose the former, so the more this can be seen as a sort of system plan rather than an ICB commissioning plan, the better, I think, because we want to be sure that we continue to all be in the same kirk and all be pulling in the same direction.
Did you want to respond to that?
Yeah, if that's okay, Chair. It's just to say that I absolutely agree, and that, as you say, this is our 5-year commissioning plan. But in parallel to that, the work that as a system leadership community we've been is around building that transformation, that system transformation programme that enables a lot of this to be delivered. So I think it's those two things together that need to ensure that we do realise this.
Thank you. Una?
Just reflecting on that, what success and measuring it. ICP partnership in Cornwall, we actually have in the different life course in which we've actually set those objectives clearly, because then again in a system way it's owned in partnership. And just thinking of that golden thread of the health and well-being strategies and everything else, having those strategic outcomes and then the widgets affecting those, because there is always the public health looking at outcomes, NHS looking at activity.
So this builds for me on something that Steve said earlier on. There's something about if we have a blueprint of success of how it works, how we actually share this without recreating the wheel somewhere else. So that's the exciting part about the new team coming together. They'll be able to share some of their best practice with each other because it's good on both sides. Okay, colleagues, let's move on, if that's all right, to the recommendations.
Steve a general measure of satisfaction, which I think is absolutely right. The benefit of a 3-year plan is you can say when you expect that to hit, couldn't you? Because I'm just very aware that there are going to have to be some difficult decisions that may not be very popular. And if that's your main measure of success in the early stages, it might prevent you doing the right thing. So it's something about when you want to see that increase.
That's a fair challenge. That's a good call. Good call. Okay, recommendations. Are you happy to approve the summary commissioning plan for NHS Devon? Yep. Endorse the commencements of an engagement programme on the health care strategy and commissioning plan. Yep. Okay. Note the development of the transformation programme to deliver the 5-year commissioning plan. Okay. Agree that the case of change for cardiology and cardiovascular services will be incorporated into the wider system transformation programme, aligning it fully with the health and care strategy, commissioning plan and emerging neighbourhood model. Una.
In light of the conversation, do we need to add something about actually looking at how this will be monitored and evaluated?
Yeah. Philip, if we could add something along the lines with a methodology and monitoring vehicle, you'll find it's a better set of words. Thank you for that. Excellent. And finally, to note that cardiology will not proceed as a standalone speciality review, but will form part of a whole system approach to planning safe, sustainable and equitable specialist services for Devon. And where necessary across the peninsula. It's almost intuitive now, isn't it really? Okay, thank you very much, everybody, and thank you, Libby, on that. So let's move on. Now we're moving on to the section 75. Are we okay for Anne to stay in? Yeah, we're happy for you to stay in the room. Yeah, good. Thank you. Now we originally had planned a paper, but we now have moved that to an oral update. And I think, Libby, you're going to share with us an oral update.
Thank you, Chair. So I wanted to update the board today on the work that has been underway in relation to the existing Section 75 agreement between the ICB, Torbay Council and TSD. So over recent months, we've been working really closely with the Trust and the Council regarding the future of the existing Section 75 agreement and the integrated health and social care model as part of that agreement. Our discussions have been really constructive throughout, and all partners remain committed to doing what's right for the local people, their carers and families. This is a really long-standing and complex arrangement, and we absolutely fully recognise that there are operational and financial pressures facing both organisations within this agreement. And we also understand Torbay Council's wish to maintain the benefits of that integration whilst ensuring improved delivery and value. The Trust is considering their position in providing services under the current arrangement at their board meeting, which is happening later this afternoon. Our position as an ICB is therefore based on the possibility that the Trust will confirm its intention to issue notice to its board. Should the Trust board reach a different conclusion, we will obviously review our position accordingly. So therefore, if the Trust board confirms that they are going to give notice to terminate its participation in the Section 75 agreement, what will happen is that this will start a 12-month notice period from that date. And during that time, that 12-month period, we as an ICB will work in partnership with the Council to support the delivery of adult social care for local residents. I think it's really important as well to be clear that we will also use the 12-month period, that notice period, to work closely with all partners to shape a safe and sustainable future service model that meets the needs of local people and aligns with what I've just presented to the board, which is our one plan for Devon as part of delivering our health and care strategy through that 5-year commissioning plan and transformation. So this will include a detailed review of services that are currently integrated through that Section 75 agreement, operational and financial analysis, and most importantly, further work to understand the impacts on people who are currently using services, including on their carers and families. Really important to stress that at this stage, no changes to those existing services have been agreed or implemented. And the notice period, the 12 months, provides the time to undertake this work thoroughly and to involve and inform our public and our communities, including those directly affected, should service changes be required as part of these changes. We have undertaken some work as partners and reviewed an initial equality impact assessment, which does give us an indication of the impact that a decision by the Trust to withdraw from the agreement might have. But we do need to continue to do that work as partners to fully understand the potential impacts and the implications of any future models of care. So the Torbay Trust board does meet later today, as I said. And so at this point, I ask that the board notes our provisional position, which is based on our current expectations and subject to the Trust Board's formal decision later. And again, to stress, we as an ICB remain committed to supporting both the Council and the Trust throughout this period, and I'll continue to update the board as this work progresses over the coming months. Thank you, Chair.
Mark?
Yes, I mean, I should add, I mean, Anne-Marie no doubt will want to talk about this. Anne-Marie and myself and the Director of Adult Social Care with Libby have chatted about this. John, you know, I think this creates opportunities potentially for us to build really a new care model and an opportunity really to offer some exciting alternatives to people in our system, and I fully endorse what the approach that Libby's outlined, and you know, want to say that we want to work very closely with our colleagues in Torbay and South Devon Council and TSD in making that a reality for our communities.
Thank you, Mark. Anne-Marie.
Thank you, Chair. And reference has been made to the long integration. So that is a 20-year integration. And for colleagues around the table, I think it's probably fair to reflect that despite my knowledge of the levels of integration, work over recent months has even surprised me in terms of the level of health activity that is undertaken by our social care workforce. That does lead to then significant concerns in terms of the equality impact assessment, and I recognise that undertaken by the ICB in partnership with both us as the council and TSD is indicating that there are indications of significant change in health. And then that poses significant challenges in terms of TSD making the decision that they are proposing to make later today without having consulted our communities on that change prior to that decision. And we'll need to think through how we address that after any decision is made today. Because of that concern and the lack of consultation, important for the board to be aware that Torbay's health scrutiny has referred this matter through to the Secretary of State, Secretary of Health. So that is under consideration there as well. Whilst absolutely we will work together and look for those opportunities. I don't think it can be underestimated the amount of work that will need to take place over the next 12 months to move forward and not have the combined services that we do today. And therefore, in order to get to a safe and legal position on the 1st of April 2027, that may not give us all of the time required in order to be as innovative as we would want to be, which is why, in the work with Libby and yourself, Chair, over recent weeks, sought to have a further 6 months of work in order to give us that time. So therefore, the giving of notice may inhibit the ability to be as innovative and to lessen the impact for our residents that we would want it to have. But a sad position to be in, Chair. Sad position.
Thank you. Frank?
I'm not close enough to the reasons for why they might serve notice at this point in time. But it does seem bizarre. It was an exemplar 20 years ago of integrated working. We're talking about a culture where people will do the right thing for the patient in front of them, whether they be a health worker or a social worker. And we are going in the opposite direction in this decision, or it's not our decision, but in their decision, is going in the opposite direction to what we need. We need a culture where we deliver for the people of Devon. And I just find myself flabbergasted that this is the direction of travel when the rest of the country has been encouraged to go the opposite way.
Anything you want to say? No? Steve?
I feel it's difficult to comment on because I haven't got any, there isn't a paper, I've got no detailed knowledge of the matters at hand other than what I read in the media. Okay. So I find it difficult as a board member to respond or give a view and not being cited on the detail.
Thank you. I think one of the opportunities that Mark touched on is that this does, assuming it goes the way in which it does this afternoon at the Trust's board, the opportunity to consider what the service offer is, Frank, actually. And there may be elements of more primary care and general practice in any future model, a different way of doing it, and that. This is an opportunity, not an ideal way of going about it, by the way, from my own personal view, but that's where we're at as a group. Yeah, Libby?
Yeah, absolutely agree, Chair. And I think, in setting out the commissioning plan, we can see that there's, not where we would want to be, but a real opportunity to think about how we bring that commissioning plan to life for the residents, working with the council, and how best to do that while the next 12 months of notice period happens. So, we've got the framework there to do the work, and the willingness of partners to do that. So I think, the focus needs to be on how we minimise the impact on residents and develop a model that's fit for the future.
Okay. Neil?
I agree. I hope that it will be seen as an opportunity to look at a new model of care, but I'm also slightly anxious that in something that was seen as an exemplar, and we were looking in Cornwall 20 years ago at what was going on and thinking, wow, that's great. If there are any generic lessons that can be learned about how an integrated system went wrong, it would be helpful if those could be learned and known about, given the spaces we're beginning to enter.
Okay, well, I think we've had the opportunity to hear our position on this. I think the way to take this forward is to note what you've said going forward. Obviously, we'll note and record Anne-Marie's points for the record, Anne-Marie. I think that's important, and the other observations from board members. But I think all we can do at this point is note it and see what happens this afternoon. Libby, happy with that?
Yes.
Right, board colleagues, thank you very much for that. Let's move on. So let's move on to the Devon Dementia Strategy. So I think I'm right. Have we had a Devon Dementia Strategy in an ICB before? Have we had a Devon dementia strategy? Okay, so it's on the table as a sort of a first pass, as it were. Delighted it's come to us now. Phil, are you going to lead on this, or is Libby going to lead on it?
Libby will, but I'd also like to introduce my colleague who will say a few words. This is Emma Elston. She's the Service Director for Older People Services within Devon Partnership Trust, and she's coordinated a lot of the work with voluntary sector partners in getting to this space. So she was planning to say a few words after Libby's introduced the item.
Okay, so Libby's going to go first.
Yep.
And then we'll go to Self. Lovely, thank you.
Thank you, Chair. So I'm not going to say much. But this work around the dementia strategy has been underway for some time in Devon, and took an opportunity as part of the health and care strategy work that we did last year to refresh and look at a proposed new approach to prioritising this as part of the work that we need to do through our commissioning intentions. So if we can take the paper as read, but huge thanks to Emma for joining today, who I'm sure will be able to bring to life some of the key points.
Thank you. Thank you for having me here today as well. So as we've already discussed, the strategy was originally developed in 24-25 with a huge amount of engagement across all of our system partners and a significant amount of co-production through people living with dementia, carers, and our voluntary sector colleagues. So you may well be aware that in Devon, certainly for the Devon Partnership Trust footprint at the moment, there isn't a onward post-diagnostic offer for people who have diagnosed with the dementia. Essentially, there is an initial 4-week offer from Devon Partnership Trust, and then there's nothing unless that person develops significant needs that require them to come back into services. Now, we are seeing the growth of that gap increasingly. So currently around 30% of people in Devon in a hospital bed have a diagnosis of dementia, and a significant number of those admissions could be avoidable. They're due to things like UTIs and things like that. So what we did was we took a look at the strategy again at the beginning of this year and did a bit of a refresh with the knowledge that kind of nationally, but also very pertinent to Devon locally, we're expecting a 54% increase in dementia prevalence between now and 2045. And regionally, we are a significant outlier if we look at the kind of growth of our over 65 population. So this is a challenge that is growing day by day now in our system. So we took a look at it again from that point of view and just did a light touch refresh, bringing it back into kind of being a 3-year strategy fit for now. And also looking at what would it take to bring this strategy from strategy into delivery. So for us, that includes a few things. It included thinking about what we already achieved. So when we did the work about a year ago, there was such strong commitment from the partners involved in that work that actually lots of things have happened without us doing any investment and things like that. So, for example, we now have World Health Organization age-friendly community status across all partners in Devon. We've done some really innovative work looking at our kind of rehab services and aligning them to support people with dementia. Our voluntary sector services have been appointing dementia champions and doing some work in their local communities too. But to move this from those smaller scale individual things into a kind of county-wide offer that is fit for purpose, we are looking to now think about what investment would be needed into that to make that change. So the details of that are outlined in the paper. I think it's probably important to note that this aligns with the national thinking and priorities. If we look at the modern service framework that's about to come into play and is being developed now, looking at dementia. I was in a meeting this week with Jeremy Isaac, who's the clinical director for NHS England for dementia, who was talking about one of the priorities within that framework will be a standard post-diagnostic offer being available across the board, as well as looking at waiting time reductions and looking at hospital stay admissions and things like that. Also ties in nicely with the work that we need to do around neighbourhoods. And the VCSE offer defined by both Devon and Livewell in this paper really talks to how could we meet people at neighbourhood level, which is obviously the thing that we need to be working towards going forwards. So what you have here is a kind of description as to year one, what would we really look at? And we're primarily looking at offering a standard post-diagnostic service to everyone diagnosed with dementia and their carers. The top thing I hear from carers, which is incredibly sad, is that We don't know where to go. We get left with this diagnosis and we have nowhere to go. I hear routinely from my primary care colleagues around, I recognise this person has a challenge, but actually diagnosing them doesn't feel like it changes their situation for them. It doesn't get them access to support. This would be the start of changing that for people and making that kind of meaningful change. And also looking at what we offer into our care homes. So really thinking about how do we make sure that we support people well where they are, be it at home or be it in care homes, to avoid people coming into hospitals unnecessarily and managing that work way through. I think the final thing that I would want to say is that we have also been working closely with both Exeter and Plymouth universities, and we have already aligned PENARC to do a review of the strategy at midpoint and to work with us using the Dementia 100 tool to really assess kind of what the remaining gaps are in Devon and how we might look to close them. This is very much intended as an initial strategy to kind of pull us back to baseline and where we need to be. Thank you.
Okay, thank you very much. Mark.
Yeah, I welcome this, I understand from Simon it's part of it's in our financial plan, just for colleagues around the table. Reading the report, the issue I think I'd like to raise is actually looking at this as a value-based healthcare proposition fundamentally. In the alignment of the funding in year one, we identify the impacts really that we're trying to drive at. I'd like to sort of see those quantified. You know, what are the intended impacts? So, for example, across the system, we're saying we might reduce avoidable admissions. How many? How many have we got? If we put the support in, what would that do? Thinking about Chris's 8 measures for neighbourhoods, you know, where are our most inequitable access to this? I mean, I think, you know, do the middle class areas have more nous and more ability to navigate support compared to our working class areas? You get a flavour of what I'm saying, Phil. And I think that needs to probably be done with system partners in I can't remember whether this is Devon or Cornwall or both. Is it Devon? It's Devon, okay. With the Devon partners, so that what we're doing is working in a system way to evaluate the measures, yeah? And obviously use family and where possible patient feedback on the support. It will be essential, won't it? But it's a huge gap. The other question for me is if we've got you know, given the parlour state of our finances in Devon, if we've got a real opportunity, Phil, to avoid more admissions by giving you more money, and you're confident with that, then for goodness sake tell us, because actually the acute sector will be, you know, really will want to embrace that, I'm sure. And we need to look at it as a value-based proposition across the system. Does that make sense? So I would quite like to see what are we, not the words, actually the you know, the outcomes that we're trying to achieve here, because it seems a very small amount of money for quite a lot of outcome, you know, and that's terrific. But I don't want you to sort of limit your aspirations to what Simon is prepared to give you. If we actually look at, on a serious note, if we looked at it, you know, having worked in Wales, it's not. Having worked in Wales, John, this notion of value-based healthcare is very underdeveloped, I think, in England. But what we'd be looking at there is fundamentally what are all the interdependencies and what are the allocative shifts we need to make in order to, and how do we share the benefits of those allocative shifts between partners. So I'm just trying to encourage you to think that way, really. And I think we need to know what those outcomes are, Libby.
Okay, so there's a number of people who want to speak. I'm going to give Phil bear with me. I'm going to give Phil the first chance to come back, and then we're going to go Phil, Diana, Lincoln, Frank, Steve, Neil. So, Phil.
Wow, that's great. There's so much interest in this as well. I just want to say thanks, Emma, for that fantastic opening address. I've never seen somebody fold their arms so quickly after than Simon did there. It's not hard to read.
Don't worry, we're taking on the strategic commissioning course.
I mean, the thing I'll say is we definitely will not limit our ambition. As Emma said, this is a start. Yeah. So the thing that has to happen after today, because I sincerely hope the board endorses what's proposed, is we need to go into implementation phase, don't we? And that's where we start setting out some of these measurables. We can start to test and recalibrate what the possibilities are. Emma described the link with the universities around evaluation. We can build that all in. But I don't want to miss the opportunity to say thank you, Mark, for your support with this. And absolutely, we won't be shy in saying if there's more needed. But I also accept it has to be part of understanding the economics of the case and how it fits with overall healthcare resource.
If I can bring the same litmus test that we're doing in neighbourhood work, there is something here about embedding it at neighbourhood level, but also the evaluation of it that will allow it to be scaled. Cannot be underestimated, which is why I completely endorse that point. Okay, Sam wanted to raise something as well, so we're going to go. Diana was next.
Thank you. So the VCSE across Devon supports and endorses the strategy. It's really welcomed. As Em says, we have been really involved in the formulation of the strategy, and we believe it could form an important part of our left shift approach that we've been discussing all day, really, in particular in relation to empowering and supporting these very vulnerable people across the county. I think absolutely agreeing with everything that Mark has set out, and some of the things I would have said had you not said them. I think the other piece for people to understand is the strength of feeling across the VCSE about this strategy. Because we've been so good at engaging and involving and co-producing the strategy, I think it would have a really detrimental effect. We'd have to do some really clever work to think about how we could not have a really negative approach when this strategy has been born out of some really good co-production work. I agree that I feel that there is a further piece to be done, and I would like to propose that that piece is led by and with the voluntary and community sector in complete co-production and partnership with our statutory sector colleagues, because this does seem to be an area where we do have a significant amount of expertise.
Take that. Can I just bring everyone in first? And maybe respond to that. I'll ask you to maybe wash up a bit with Libby in a second, if that's all right. So we're going to go Lincoln next.
Yeah, just echoing that as well. It's good to see it move forward, because we were worried there was a point at which on again, off again. So good to see that happening. It is the exemplar of neighbourhood working. I think this is one of the practical, and I'm very much about let's find practical things that we work through. And I think this is just a perfect example. Yeah. The third and final point I wanted to make, and it's some learning that we got from SEND, which is kind of the opposite end, but it's about a needs-based approach as opposed to a diagnostic approach to support. And I think the problem we had with SEND, which created all kinds of perverse incentives, was that people felt you needed the diagnostic label in order to have the support that you need. And I think we could make a mistake here if we don't think about what is it that people and their families are asking of us, how do we respond without pushing people through a waiting list to get a label in order for the support to be opened up. So if we could solve that together, I think that would be a really good way forward.
Completely agree with that. Well said, Lincoln. Frank?
So I have a particular interest in this, and it's not just because I might be in zone for dementia by 2045. I went to the Mental Health Collaborative as this was worked up. And the reason, John, you think you thought you'd seen this before is it was all worked up to come to board pre-Christmas, and there was consternation when it got pulled. The most important thing is the voluntary sector have already moved into this space and are doing most of it already, and we need to help and support them to continue to deliver it, because it doesn't have to be over-medicalised as we go forward. It is absolutely about the neighbourhood stuff and the communities providing within those communities. But it's one of the biggest issues, well, it's probably the biggest issue for Devon Health going forward.
Thank you. Steve?
Yeah, I support that, and I welcome Mark's absolute advocacy and support for this going forward. I was struck in the strategy that there isn't a reference to acute services, and there's kind of two aspects for me. One is the point that Mark's already made about the significant transformation which could be achieved in acute services as a result of, for example, reduced length of stay, admission avoidance. I also think there's a key opportunity for acute services to be part of the dementia service delivery and the transformation. So I just wonder if there's a way of drawing that out more explicitly, not just the benefits that we'd expect in an acute setting, but the direct leaning in that we'd expect from acute partners. And not to say Cornwall has this right at all, but Royal Cornwall Hospitals has been a very active part of the wider dementia transformation. I agree with everything that's in the strategy, by the way. I wouldn't want you to misunderstand that, but whether there is something that comes back in a year's time, maybe at the time of the two ICBs coming together, that sets out that next level of ambition going forward.
Very good. In fact, a perfect segue. I'm going to ask actually Sam to go before Neil, because I think that might be able to answer. Yeah, I'll come back to you in a second. Sam, can I bring you in, please?
Yeah, well, first I just wanted to agree with Lincoln and Frank, and there's a common theme in many of the patient groups we've talked about today, whether it's social care, SEND, or this patient group. I think we're at risk of massively over-medicalising this patient group, and I'd really recommend the documentary Human Forever from the Dutch care nurse who went to live in a dementia home in Holland, and that's exactly what's going on. So I think we have to challenge ourselves collectively on that. The other bit that I would really like to for us to push the envelope on would be more wearables. So I think there's a digital angle to this that we should be really ambitious about.
It's a good challenge. So we're going to go Neil and then Chris.
Thank you. I really welcome this strategy. I felt there was a subsidiarity about it. It was from the bottom up, and the involvement of the VCSE was really important. I'm fascinated, whilst I'm keen to support investment, I'm fascinated by your comment that it's already things have started to happen, and that's an example of what we need to do across neighbourhoods, because there is often not knowledge of what's available in your local neighbourhood. And a number of years ago, I was tired of chairing meetings where everybody said what you just said. There's no point in us doing all this work to diagnose because we can't offer anything to anyone. And so we convened a meeting upstairs in St John's Hall in Penzance and had a dementia lead come in and talk. And downstairs we had a fair with all the voluntary sector who were already wanting to offer more for dementia patients and families. And I trooped all of the GP and staff downstairs, and things changed from that moment onwards. It was just more knowledge and more ability to know what was out there to support people and who to contact. And it's about making connections. And it's really important to do that. And I really welcome this. I hope it's a great success. Also, I wanted to say, don't forget, and if Tan was here, she'd be saying this. Is she? Tan, I was going to say, this dementia strategy is a lot about the carers strategy as well, because the burden on carers is so significant, and lots of other impacts that has.
Well said. Chris?
I'd just like to make a proposal, Chair. If we're going to adopt a neighbourhood framework as our model of care for delivery, be it a dementia strategy or any other long-term strategy, those eight outcomes of success, one of which is reducing acute demand, one of which is improving the customer experience. It would be really good that in any strategy we do, in terms of the benefits, we stipulate through those 8 domains what the intended improvements are, and then the board's got a measurement to track it as we go. But we also then get consistency in whether it's dementia or COPD or cardiovascular. It would make things, I think, a lot easier for us to get transparency on whether we're achieving it or not.
Well said, Chris. Yeah. Okay. So, Libby, before I offer the opportunity to Phil to have the last word, if that's all right with you.
Yeah. So
what would you like to add?
Yeah. So thanks very much. Some really, really great suggestions there. I think, the key message is that this is really welcomed for this group of people and their families. I think Diana and I have lots of conversations about how, we're at probably more at the start of a journey than colleagues in Cornwall, and we've got a lot of work to do to ensure that we work in the best way with VCSE, but there's a real commitment to that, which Diana is aware of. I think the other thing for me is linking it back to what we talked about in terms of the commissioning plan, which is really understanding those benefits and delivery and linking it through to where the impacts will be seen. So I think, again, the frameworks are there to do this. We just need to build the detail of the delivery now. So thanks for the comments, really helpful.
Phil, we're in your hands.
Ooh, that's dangerous. So it's been a fantastic conversation. I'm really grateful to everybody for that. This is not the limit of our ambition at all, but it is a start and an important one. So the other thing I would want, none of us would want this to happen, is the board can't lose sight of this. I think it's a really important moment for Devon, given we've all acknowledged this is one of the, well, if not the biggest challenge. So we're going from today, I think, with approval. But also to get on with it and start allocating money in line with plans. The vast majority of the funds that have been earmarked in here are for voluntary sector, not for statutory sector organisations. That now needs to be worked through, developed into contracts, and we get on and measure the outcomes. So
can I just
that's what I'd be looking for.
Are we going to, before we push the go button, are we going to get the outcomes before we push the go button?
I think, Phil, it would be. I mean, some of this stuff you can mobilise already. We just need to get from yourself and your colleague what those outcomes look like. But that shouldn't impede giving the voluntary sector the resource. Diana, I think what if we've got avoidable admissions, given what we were saying in the early part of the meeting. What's really choking off our ability to invest in your sector and in other sectors is we never quite get to the point of reallocating our resources to the right places because we never make the reductions in year that we need to make in certain sectors to transfer to another. So I'd quite like us to sort of say, well, co-produce with the acute sector, Phil, what the changes and the voluntary sector, what the changes could be in avoidable admissions, for example, because I can see a direct line there with releasing resources. Just tell us what that looks like, based around your improvement effort. And Diana, I think when it comes to the voluntary sector, we've got to make sure that the sector understands that maybe in year one we want to concentrate on things that are releasing value for the efforts we make through the commissioning of the voluntary sector. So there's a dynamic to it. Does that make sense, everyone?
Yeah, I get that. Yeah.
So completely agree with all that. Absolutely, we need to support the voluntary sector to understand how best to measure and articulate and communicate what changes they make across the whole system. And I think that's where, between us, we can make that change. I think culturally, just in case you're not aware, culturally we've moved to that space as a sector in terms of our investment. We understand about that. I think practically there's still some development work to do.
Yeah. Okay, so I'm going to make a suggestion in terms of tweaking some of the recommendations one by one as we go through it. But I'll fly the kites, and then you can tell me whether you like it or you don't. Okay. So the first one is to endorse the refreshed Devon Dementia. Is it refreshed or is it? This is the first time we've seen it. Yeah. So it's hardly refreshed, I would suggest. So this is endorse the Devon Dementia strategy. Yeah. For 26-27 to 28-29 as a system-aligned framework for dementia delivery within Devon. Could I suggest we make sure we suggest maybe delivered at neighbourhood level, just to endorse the point that it's a neighbourhood really initiative. And I just want to pick up on Steve's point. Would it be helpful to ask the question while clarifying the role of acutes can play going forward, or is that a stretch too far?
Acutes have been part of the development of the strategy.
They have. Oh, okay, fine. In which case, ignore that. Okay.
I think you can co-produce the benefits, Phil.
Okay.
Yeah.
Yeah, okay, so we can say at neighbourhood level. You're happy with that addition? Yeah, okay. Note the progress already achieved by system partners and the intention to move from strategy into a planned phase. I think probably more than, that's a very strong note by the sound of it. Support the proposed Year 1 delivery focus on strengthening post-diagnostic and care home support, delivered in partnership with VCSE organisations aligned with other wider systems. Are you happy with that one?
I'm completely happy. As you can see, I'm very jolly about this because I just think it's the future. And so I'm so sorry, John. You know, I don't think we should limit our ambition if we've got more avoidable admissions than $1 million does us. The acute sector ought to be investing in it, put simply, because actually these patients are in the wrong place if they're there, really. Fundamentally,
okay, well,
can't help them.
It's a beautiful moment then to move on to the next point, which is about the money. So I no doubt the CFO's just had a cold shower coming back in, but because it's more than note is what I'm hearing. I'm hearing that we are agreeing the indicative scale of Year 1. What I'm hearing though is subject to the outcome measures agreement. Yeah, you could buy that. Well, it's subject to the outcome measures across the Devon system to approximately £1 million. That's for you as executive group to agree once you've agreed the outcome measures, recognising that any funding decisions will be subject to prioritisation agreement through the appropriate sovereign governance and financial planning routes. Is everybody happy with that and those tweaks I've made? Yes, Phil?
Can I just make a comment about the subject to bit?
Yeah.
So I completely agree. We've got to work through what are acceptable deliverables, right? I don't want us to lose sight of the fact that when Emma introduced this was largely about getting us up to a baseline of acceptability.
I understand.
Yeah. So in the subject to, can I just check that we're not going to get to if it pays for itself through avoidable admissions, because it is not going to do that in this first phase.
No, you're not. So when what's going through my head, Phil, is actually the benefits might be more considerable if the acute sector comes to the table with you and look at the joint benefits, because we have a significant number of people who have got mild, moderate frailty linked to and/or dementia that are coming through our front doors that actually we should be managing in a very, very different way if they're in terms of their exacerbations.
So should we move something, Mark, to something that basically suggests that Phil tweak an element of this and come back to you pretty quickly, and we just delegate down to you to agree with.
Yeah, I can do that. Well, Libby can do that with Phil. I mean, I'm not thinking of a 3 months.
So my bit is it's subject to understanding what you're buying for the money, really, isn't it? Not that there isn't a commitment to do it. It's understanding the detail.
I mean, we want to know what we're going to get for it.
Right. Yeah. There's a lot in that. So can I just turn to the company secretary and say, are you happy that you know what we just agreed?
Yes, I think so. I think the agreed. The scale of funding and delegated, subject to delegated authority to Libby Ryan Davis to agree the outcomes.
Can I just add, so I think what we're also saying is part of the next 3 weeks as we finalise our submission as a system, we're agreeing to support this, and it's part of that process over the next 3 weeks to ensure the funds are moved in the right direction to make that happen.
And sorry, I probably have been inarticulate in this. To absolutely support Simon, if there's a further allocative shift that the acute sector can make in terms of not just doing the de minimis, Phil, but actually giving you more money that actually enables us to release admissions, we need to talk to them about that, and that needs to come on the table. Do you see what I mean? Because that's a value-based healthcare approach, isn't it, that we all want to see. We don't want to see our patients not benefiting from early intervention and support that prevents them being admitted to acute beds. Yeah.
Thank you. So, Emma, do you realise the impact you just had on this board? Well done, you. Well done, you, and you and your team. Phil, are you happy with the summary of that?
Yeah, that all makes sense.
Lovely. Thank you very much. Thank you, Emma. Thank you. Okay, just final 2 points. Support the delivery focus of strengthening post-diagnostic and care home support, subject to prioritisation and funding decisions, and support the use of structured improvement evaluation mechanisms as set out, just with the proviso that you really do nail the evaluation of what works so we can scale it based on what you find as well. Yeah, done. Thank you very much, everyone. Great discussion. Okay, I think we'll forgive ourselves for being 2 minutes late. Okay, so as we move on to caring in Cornwall, all-age carer strategy and invitation model led by Susan. Is that right, Susan? Are you leading on this?
Can you hear me okay?
Yes, we can. Thank you.
Apparently, I'm having some sound issues with the laptop, so apologies. Okay, thank you, Chair. This follows on beautifully, actually, from the previous paper and some of the conversations that we heard this morning, highlighted by Minal and the team around neighbourhoods. And as Mark would say, it's another value proposition, but easily replicable across into Devon. That is the beauty of this strategy. So I would like to have on the minutes my thanks to the team for doing work across our system to bring this together. It's a great piece of work and something I think they should all be very proud of. So the paper that you have in front of you, I'll take as read. However, there are things, Chair, that I would like to bring out if you wouldn't mind.
Yeah.
So the paper presents a system-level reset of how we support carers across Cornwall and the Isles of Scilly, moving very much from a fragmented provision to a coherent, preventative, neighbourhood-based model. And as I say, this can be replicated across into Devon when the time's right. The beauty of it, it's been co-produced with 800 carers aligned to statutory duties and designed to address a significant gap between needs and access. The paper sets out an overall investment envelope and delivery model, but the detailed financial profiling sits beneath this, and we will be managing that through the Better Care Fund governance and commissioning process. I'm very happy to bring back something if you want more detail on the finances. So why does this matter? What's the case for change? There are currently 54,500 unpaid carers, approximately locally, but only around 10,000 currently accessing support. Many carers present late, often in crisis, driving avoidable demand across health and care. Some of that will be undoubtedly admissions to acute trust when things break down at home or loneliness strikes, which is often one of the drivers. So again, it dovetails with what we've just been talking about. We know that caring is associated with poorer health outcomes, financial strain and social isolation. And locally, our challenges are amplified by our rurality and access barriers, ageing population, rising complexity, and hidden and underserved groups. The bottom line is, if we have a high resilience, a reliance on carers, but a system that under-identifies and under-supports them, we do need to do something about it, and that's what this strategy is around. So what's changing? So this strategy should move us from, as I said, fragmented reactive services to a single integrated life course model. And at its core, carers services are embedded into integrated neighbourhood teams and at place. It's supported by 4 specialist pathways. Again, this is being done with our carers and what they've told us. So young carers, we know there's a high number of very young people, often at 9, 10, 11, looking after loved ones. Dementia carers, patient carers and mental health carers. So our key design principles include early identification, not crisis response, place-based delivery and a whole family approach with a single front door with a targeted specialism behind it. So the outcomes that this will deliver, and I think it's part of what you were talking in the last, is the model is designed to deliver impact into 3 areas. So prevention and demand management, early identification leading to reduced crisis escalation, better support leading to fewer breakdowns in care arrangements, expected impact on avoidable admissions and safeguarding pressures. From a quality and experience perspective, faster, more consistent access to assessments and support, improved carer well-being and resilience in continuity of care, and carers recognised as partners in care delivery, incredibly important. They carry a huge amount of work that would otherwise we would have to deliver in health and care. From an equity and inclusion, we're targeting an outreach aligned to a core 20+5, focus on hidden carers and underserved groups, and improved assessment rates on excess equity. The financial and delivery model in all of this is it's funded through a 2.45 million per annum via the Better Care Fund. And this was enabled by a revised Section 75 agreement for joint commissioning, phased implementation to manage any transition risk. So we know there's always a risk when we move into something new, and supported by a prevention and innovation fund, clear governance via Carers Partnership Board. So the value proposition is that this is a reconfiguration, not just an investment designed to release system value through prevention. So the risks and mitigation very quickly, key risks, rising demand, workforce capacity and transition disruption. And our mitigation is the neighbourhood-based scalable model, integrated workforce with INTs and phased mobilisation and strong governments. This strategy is tightly aligned to neighbourhood health model, the Start Well, Live Well, Age Well framework that we are working with our partners in Cornwall and the Isles of Scilly, the integrated system prevention agenda and emerging ICB cluster arrangements. It critically positions carers as a core system asset and not just as an adjunct service. So the recommendation is this is a highly aligned, co-produced and deliverable strategy that addresses a known gap in our system, and at its core this is a shift from reactive support to proactive system design. It's less about a new service and more about reconfiguring how the system recognises and supports our carers. It strengthens prevention, improves equity and enables carers to sustain their role, which I think, and I'm sure you'd all agree, is fundamental to the resilience of health and care services. And I'm really happy to take any questions, Chair, because there'll be things that I haven't covered off. And some of the comments that you made in the last strategy around how do we measure this, there's a variety of ways of measuring success, I think, with this strategy. So I'll leave it there for now and happily take questions. Thank you.
Usually I'm going to ask the questions first, if that's all right, just so I can be really clear. The 2.45 million is in the Better Care Fund.
So it breaks down at 1.5 million from the ICB, plus we've put in an additional 250,000 for dementia, from a dementia perspective as well. So it's through the Better Care Fund.
So how much has come from the Better Care Fund?
So in total it's 2.45 million that's sitting within the Better Care Fund.
So the point I wanted to make is for... is Ali still on the call? I can't see. Okay, so you know, as you and I and colleagues sit on the Cornwall Health and Wellbeing Board, come joint committee, this will have gone through that? Yeah, I think it was hopefully a rhetorical question, because on the basis, Susan, this is for me is a really good example as to where a functioning Health and Wellbeing Board come joint committee actually can come together on things like the Better Care Fund and actually co-create almost the right thing to do. Have I understood that right, Susan? As a
Yeah, and I have to say, John, this is yet another example of a big piece of work that's been going on quietly in the background, responding to the demand and needs, in part through some of the work that Lucy Tewson and the team have done around engaging with the community. And this is some of the feedback that we've been working on, but absolutely yes.
Yeah, so I just wanted to draw to Mary's and to Anne-Marie's as an example. This is an example for me where actually doing things at that sort of joint committee level, particularly with the local authority, trying to understand the Better Care Fund is a good example where spending co-pots, if I can put it that way, together, is a really good way going forward. And can I also then ask the question that's based on the previous discussion, which is, can we make this subject to agreeing like we did the last dementia paper? Can we make this subject to agreeing the outputs that actually come from this in the same sort of speedy turnaround? Susan?
Yeah, absolutely. And as I said, and it's in the paper, we will be tracking those lead indicators locally, such as increased assessment rates, early identification via the carers registered, and reduced crisis referrals. And that starts to demonstrate the overall system impact over time. I think this is something that you could see through the IPR, and it goes back to Steve's point about how we start to disaggregate our IPR based on a range of equity. I think this could be one of them.
Okay, well, I'll come back to it. You want to go first and then Town?
Yeah, I think it's making sure that the co-chairs of Age Well oversee the successful delivery of this and then report it in. Because, as I say, Chris and Ali jointly...
and that goes through that Health and Wellbeing Board,
that reports
through the
joint committee in common, and we can put metrics on there.
That's a cracking idea. Chris, are you happy with that?
Sorry, Chris.
The only caveat to that,
and young carers.
Is it's all age.
Yeah, it's all age. Yeah, it is all ages.
Yeah,
but
we actually need to apportion out to the different groups.
Absolutely.
So that's what we need to go and do, is the three stages. The chairs will portion out the...
And for those who don't know, those life stage groups are co-chaired by a council and an ICB person. I don't know whether you knew that, but that's the way that goes through that joint committee. Susan, anything else before I move on to Tarn?
No, you please
Lovely.
move on.
Yeah, Tarn, please.
I wholeheartedly endorse this paper and this approach. This is a real example of what we quite often hear in this board about co-design and co-production. This is proper co-design and co-production. It's with the people, with the lived experience, not just a group of professionals. It's proper joint working between the council and health. I absolutely endorse it. And we had some discussion at Workforce about how important carers are in our workforce. Without our carers, we would be so lost in terms of our health outcomes. So I fully endorse this paper.
Thank you. So I'm going to move on to the 2nd of April, just for a moment, Susan, when the new executive team's in place. Why would we not wish to do something similar from the Better Care Fund in Devon? Why is this just a Cornwall scenario at the moment?
I think for now, this is a piece of work that's been ongoing in Cornwall and the Isles of Scilly, but as I said right at the outset, this is replicable across into Devon, so I don't see why we wouldn't.
Yeah, I think we'll lose a year. That's my point. Yeah. If we're not careful, can we find a way of not losing a year?
Yeah, so I think we can pick that up quite quickly and look at how we can replicate. But I, having not had a detailed conversation to date, suggests that Susan and I pick it up offline, and then we can have a look at how we can do that.
So, Philip, if you can help me with the minutes in a second in terms of the recommendations. Any other points anyone wants to make? Frank?
The Devon situation at the moment is there is Devon Carers, which is a charity that is run out of West Bank that people can approach and they will get advice and help and support. They were also running young carers. That has just been taken back into the council, and I'm not quite sure why. But
which council?
Devon County Council.
Devon County Council. Okay. Anything else? If not, we'll move to the recommendation.
So Susan, you have raised this. Just to treat everybody in a fair manner. Phil got a bit of a we went on a bit around the outcomes earlier. I think in terms of this one, I think we just need to see what those outcomes are that you've obviously worked on and what that does. I also would quite like to see the joining up across the system of what the support for carers will do in terms of actually reducing some of those avoidable admissions potentially, and the other output measures that you identify. That would, but we can take that through the executive.
You're quite right too. Okay, in which case I'm going to be looking to Philippa to help me as we go through the recommendations on here. I think it's more than just approve this based on this. So help me. What do you think from your summary of what you've just heard is a better set of recommendations?
And I think there's a similar point to the one on the previous item around the delegation of authority to agree the outcome measures that doesn't hold up the implementation of the strategy. For me, there's a question about whether it's a delegation to an individual or whether it's that delegation to the co-chairs that was discussed previously.
Would it be to you, Mark? Or?
Well, it's a BCF fund, isn't it? It's BCF resources, so I think it's got to be jointly between the partners in the BCF and whatever the appropriate mechanisms for that are.
So Susan and Ewan, just help me there. Who do you think that should be best for us to minute?
So I'm depending on what Ewan thinks, I think you're absolutely right. It should. I know that we like to have one or two names in the frame, but I do think this is something that needs to drive through that life course group, which is what is in the paper. I'm happy either to pick it up with Ewan offline or Ali.
So can I make a suggestion? As this is the ICB board, can I make a suggestion that we delegate it down to you, Susan, on the principle that it goes through the life course group co-chairing?
Thank you.
Ewan, happy with that? Yeah. Anything else you think we ought to capture?
I think there was a request for similar work to be done in Devon around the same strategy.
Very good. Yeah. And you'll update us at the next board meeting or the next appropriate board meeting. Yeah, lovely. Everybody happy with those recommendations? Yeah, excellent. Well done, Susan. That's another huge progress for us in the right direction. Well done.
Thank
I can
you.
see.
I'll let the team know.
Thank you. Look at the beaming smile you've put on Tarn's face, which is fantastic to see. Okay, let's move on to the green delivery plan for Cornwall and the Isles of Scilly. And Tracy, you're leading on this.
Thank you. So we approved the joint sustainability strategy across both ICBs back in October and committed to bring back a delivery plan. This is a.
Could you talk into the mic a bit?
This is a strategy that covers us to 2030 and sets out our progress towards the net zero for Scope 1 emissions by 2040. And it responds directly to the rising health impacts of climate change and the need for a more resilient health and care system. So the delivery plan is really translating those strategic commitments into practical actions across all of our ICB functions. The plan embeds sustainability into areas such as commissioning, clinical pathways, workforce development, medicines optimisation and so on, and is really driving that shift towards prevention-focused, lower carbon and more resilient models of care, improving population health by tackling the environmental factors that underpin long-term illness. The reason it's a plan for Cornwall is that, and what's distinctive about the Cornwall ICB's model is that climate resilience across primary care is delivered through Volunteer Cornwall. They've been successful in attracting additional external funding and national awards and have taken an approach which has enabled active travel, healthier food access, reduced pollution and stronger community resilience, so improving outcomes whilst also contributing to environmental goals. In the first year they worked in general practice, significant measurable impacts. In this current year they've worked in addition across dental, optometry and pharmacy, and the funding that's been confirmed for 26-27 will expand that into integrated neighbourhood health teams. So we've got quite a lot of our community services taking this approach. If we take our 5-year commissioning focus, where we are moving towards sustainable preventative neighbourhood-based models of care, we're reducing emissions across our clinical pathways and using better use of digital and remote options to reduce travel. We are embedding sustainability impact assessments in all our appropriate contracts and requiring sustainability in our business cases and shifting activity from hospitals, which have the equipment that emits most carbon, to community settings. And as one statistic, a GP appointment has under 1% of the carbon footprint of an elective inpatient stay, excluding the travel of the patients and their families. So we are using digital and remote options to reduce travel. Climate resilience is a very key factor of our EPRR arrangements. We've done a lot of exercises, including readiness for extreme weather and climate-driven pressures. We are looking at how we have lower carbon through our digital and AI developments, strong alignments with local authorities, VCSE and all our partners. In fact, there's a Cornwall collaboration committee that involves us and the council in taking this forward, and this is focused on ICB functions. CFT and RCHT will be doing something similar. The medicines optimisation is looking at things like low carbon inhalers and medicines waste reduction. Travel and transport also is picking up our own contracts for non-emergency patient transport, for example, and we are looking wherever we can at sustainable local sourcing in our procurement. Appendix 1 also includes our annual update. I've covered off quite a lot of that already, including the development of the plan, the ongoing shift from high carbon area care to acute care to prevention and community support, and that VCS-led resilience programme delivering proven health and environmental impacts. Just in terms of reporting, the Scope 1 to 3 emissions are reported nationally, so local NHS bodies aren't required to disclose them, but we do set out in our delivery plan how we will measure that we are having the impact we expect. The current reporting requirements are on governance, risk metrics and targets, and we'll pick those up through the annual report. From April, the board level SRO responsibility will transfer to Simon, supported by the Director of Estates, and we will change the titles in the delivery plan to reflect this new structure. Pardon?
From when?
1st of April. That's it.
Got it. All correct. Right. Perfect timing. Excellent. Great work down there, Tracy. Any questions? Lincoln?
Probably just to commend the comprehensive nature of this work. I know that there is an anchors group. I was at a webinar yesterday, and some great work on the new hospitals trust and all the fantastic things that you're doing. And I guess the bit here is about the opportunity for us to work collaboratively. Again, probably neighbourhood in its wider sense, but we get so much more bang for the buck when the big statutory sector, and if you can get your private sector partners together to do that kind of area-based approach would be really powerful, and how, as NHS organisations, we could be catalysts for doing this at scale with our other partners.
Very good.
That is really important. We've led a piece of work with the council on for the executive leadership board for all private and public sector organisations on local procurement and how we can make it easier for SMEs to attract business from the NHS, as an example of that. We have also, there was a proposal put forward from the VCSE in Cornwall into Devon, so there is that option. I don't think there was funding available at the time, but we have certainly got an approach that we know is working and attracting national interest that could be rolled out into Devon. And I think the plan is that the Devon delivery plan will come back in the first quarter of this year.
Do you mean the first quarter of the financial year?
The financial year.
Fine. Okay. And whose mandate does that fall under going forward from the 1st of April? Which director does that fall under?
Simon.
Simon. Did you know that, Simon? The answer is yes. You do now. Okay, nothing like minuting somebody's name, is there really? Okay, all right, okay. Okay, let's move to the recommendations, if we may. To approve the Cornwall and RCC Net Zero Delivery Plan as the underpinning mechanism for delivering the COIS elements of the Peninsula Green Plan 25 to 30. Happy? Yep, very good. And note Appendix 1 to this report, which gives an update on the COIS Net Zero workstream for 25-26. Yep, done. Okay, thank you, Tracy, very much. Well done, you. Okay, so we're moving on now to the Board Assurance Framework paper.
Yes, thank you. So this report fulfills two functions. One is to present the latest iterations of each organisation's BAF to the board. However, I think that the second and more important function is to respond to the conversation that was had at the last meeting of the board in public around the need for a BAF for both organisations which worked for the cluster board as a whole. So this sets out the first step towards achieving that. Namely in proposing an assurance definitions document that we would also share with the provider colleagues in NHS Devon and in Devon and Cornwall, and the risk appetite statement that we might want to think about accepting, and then finally the BAF risks for next year. Now, these are currently just risks at the moment. There's obviously not a BAF there. We need to work through that, but they are being presented to the board in the spirit of these are the potential risk themes that we would want to consider for the cluster board and for each system within the cluster as the most strategic risks being faced by each system. I would expect as we work through if the board was happy to accept them, I would expect as we work through the detail of the mitigating actions and controls, we would probably see some amendment of the wording of these risks, just so that we can really nail down exactly what it is that we think the risks are. So I would ask that if the board's happy to accept them, that we consider them in that draft status rather than thinking about them as the final articulation of the list risks. I think it might be happy to go through the report section by section to check whether people are happy with the various sections, but I'm happy to pass back to you at this point, Chair.
You lead us on the discussion, if I would.
So I think the first and probably the least contentious section is the one headed proposed assurance definitions for the BAFs in 26-27, which sets out an articulation of a level of assurance and the actions that we might want to be taking as a result of that level of assurance. This is a specific response to the findings of a piece of work that PwC undertook in the Devon system, which indicated that as boards across the Devon system, NHS bodies didn't have a single view of what it meant to, say, limited risk or limited assurance or satisfactory assurance. This has been shared with the Audit and Risk Committee chairs of each of the organisations and the governance leads of each of the organisations organisations in the Devon and Cornwall systems as well, and there's been general agreement of that. However, we wanted to bring it to this board first before we then cascaded it through for acceptance by the other boards. So that would be the first place that I would invite comments.
Any thoughts? Stunned silence. Martin.
I've gone then, John. Just, I think it's a really clear articulation and very useful. I'd be happy to endorse it and hope that others will as well.
Yeah, I felt the same. Great piece of work. I felt that too. Anybody else? No?
So I know we've got some work to do on committee structures and sort of going forward and re-looking at areas of responsibility. But am I right in thinking what one of the aims for committees is that they will try and determine their work they're doing against the risks that they're facing?
Yes, that's the proposal. But so I'm happy to work through that when we get to that section of the report.
Yeah, just to help as we get to there, I think I'm right in saying the key theme is the board assurance risks increasingly now need to become almost the key determinants of the agendas for our committees. I don't see us actually at the moment changing the number of committees that we've got going forward. We might change who attends them and some of the way they work. And that's part of the re-engineering work we've got to do. But I think we've really got to move into now having committees focused on our board priorities rather than anything else. Graham, did you want to add? No, fine. Right, take us to the next stage then, please.
Thank you. So then we move on to risk types and risk appetite. So the report sets out what we have currently in both organisations, and we're proposing that we have a risk appetite statement that works for both organisations going forward. And we've pulled that together by articulating a number of risk themes and then taking a potential view that the board might want to accept or might want to amend as it sees appropriate in terms of the level of risk appetite. I think it's important to flag, so this is set out on page 10 of the report under paragraph 22. There's quite passionate debate amongst executives about the importance of separating out quality and risk in relation to risk themes, and so we are proposing that we put two risk themes in, one for quality, one for risk, because we believe that there is a difference in probably a difference in the risk appetite for each of those, and that's set out at the bottom of page 11 of the report. So again, seek comments on that.
Comments anyway? Yeah, Graham?
I think at the last board I did make the observation that the mitigation is rarely resource-free. It takes effort, and I think that the tolerance is almost, but not quite, a surrogate for how much effort you're prepared to put in. So if your tolerance is very low and you think you've got a significant risk, then you're prepared to do more about it. So I just wonder whether there is some scope to develop it just a little bit further and thinking about what does that mean by how much effort we're prepared to put in, only by way of guidance, because I think it would anchor it in some of the realities of what you've got to do about risk. So just a suggestion for a tweak, I think, there.
Thank you, Graham. So happy to take that away. I think that's something we could probably test if we're happy to accept this as an initial risk appetite statement to be tested through the committees, and we'll talk through which committees are proposed to have which risk theme later.
Fine. Can I just therefore just test the logic of it on one basis? So if we look at the financial sustainability risk, which is a low appetite for risk, by our own yardstick, the time we actually get to sign this off in April, how do we define what low risk actually is? We've been talking about having SIP programs at one level. We've been talking about SIP programs in their own right aren't part of the whole answer for the total system. How do we actually... We've had two papers earlier on in terms of care and dementia where we talked about some of the output measures that come from it. How do we actually define what is an acceptable level of risk to be a low appetite? Because your appetite might be different to mine. So,
well, the traditional answer is, although risk and uncertainty are somewhat different, I think it's to do with the variability. So it's the range of anticipated outcomes. If it's a very narrow outcome, then I could argue it's low risk. if the potential outcomes are much wider, then I think something to do with the range that we would anticipate, plausible ranges.
Okay, so let me just go back to my challenge. When we get to the April signing off of the Cornwall and then the Devon, or more the Devon, well, how will we know that we've got a low appetite? To what degree do we have to have green on SIPs, etc., to be able to demonstrate that we've actually got a low degree of appetite?
I think that will respond to the level of assurance that the board feels it can take in respect of the proposals. So if the board is fully assured, then that meets that low risk appetite. If it is not fully assured, if there's limited assurance or satisfactory assurance, you might want to probe as a board as to whether or not that actually meets the risk appetite established by the board.
Yeah, no, I can buy that. Steve?
Well, it's on that same point about system financial sustainability. You might argue that the risks or the opportunities which have the potential to jeopardise might also be the same opportunities that have the potential to give us a long-term sustainability going forward. And with the level of transformation and change necessary across both systems to achieve a viable, sustainable financial position going forward, there is an argument to say that the risk appetite should be higher in the board. Otherwise, we won't be able to make the level of change and transformation necessary. And that's not, Simon, about saying delivering financial balance isn't important. It is, but I think this risk appetite and the associated tolerance for sustainability, in my view, might need to be considered to be higher.
Well, I think that's where I was going, because some of the things that we were completely agreeing with, and Mark, you were leading on some of it in terms of the investment in the dementia strategy because of the avoidance that it would have on the acutes and that kind of thing. There is a higher risk appetite that goes with that than low risk. I'm trying to bring us back to, I'll use a different language, we've got a low tolerance to actually signing off something that we're not going to achieve. But actually getting there, you might have some higher risks in getting there.
John, I've seen risk appetites where you differentiate between risks to your financial statutory duties.
Yeah.
So if you're going to go into a deficit position, then clearly that would have a low risk. But the things you're talking about, which might include investor saving things, you have to have a higher tolerance, don't you?
Yeah,
so I wonder if we're trying to cover off too many things in a single risk category. It's a bit like we've got digital and cyber security. So cyber security is absolutely low. But if you really want to push digital and be innovative, you need a high... So I think some of these probably need a bit of separating out so you can differentiate between what are your red lines, that's effectively what you're setting out, isn't it, in terms of risk, which is safety and for other things, I think you could be...
That's a much better articulation than I gave. So do you buy that as a...
Yes, very happy to, because I think what the initial risk appetite statement is absolutely, as Tracy described, is I think the board has a low risk appetite for risk that could jeopardise long-term financial sustainability. However, it is willing to potentially take risks in other spaces which will lead to an outcome that improves the financial sustainability.
I think that's where I'm
so
coming from.
There's something about how we break those down. Yeah.
Okay. Salma, you had your hand in the air. Did you want to say, or you not?
It's been covered off, Chair.
Lovely. Thank you very much, Simon.
Thank you, John. Yeah, in terms of risk, I think this is, where we all agree that the process we set in place to develop value improvement, I call it, year on year, we need to strengthen that, and it needs to really be not a once-a-year exercise. So there are two things with this. One is, I think, we agree that on a sort of monthly basis there is really robust review of delivery against programmes of change and what the financial impact is. So that needs to be better and be robust. And the second part is the sort of quarterly cycle of development, identifying further opportunities, driving those through and rolling them as a regular implementation process, so we're not hitting a once-a-year exercise. And that process should build robustness around the numbers we're aiming for in year. So there's a piece of work we need to do quite quickly that protects capacity and expertise to do that, despite the day-to-day routine. So that's what we need to work on.
Lots of nodding going on. That's great. Frank, final word, then we're going to move on.
It was just the additional risks for Cornwall about the Devon financial position. I mean, it's a risk for Devon as well, in that there are differential investments in certain parts of the system at the moment. So either it's a risk reflected in both, or what's the benefit in having it for Cornwall for this year when we're an integrated system by next year?
So I think, first of all, I think it's proposed that it's considered in the round of this board. So this is a technicality to reflect the fact that we have two separate organisations that continue as separate organisations until the point of merger. But the presentation of both BAFs alongside each other as a cluster BAF will mean that that is considered alongside the risks for both organisations. So I don't think there's a visibility issue. It will still be there.
Okay. I can buy that.
In terms of the Cornwall specific risk, I do think that there is a danger that focus on Devon will end up meaning that Cornwall doesn't get the level of focus that it has, which is the reason that it's been separated out. You could argue that there should be a further risk on the Devon BAF, but that would then that would lengthen the length of the BAF as well. That's the flip side of that, which is that there is insufficient focus on or that there's over focus on Devon to the detriment of Cornwall, which means that the cluster would not operate appropriately as a cluster.
Yeah. Let's get to the 1st of April 27 would be my suggestion. Steve.
I'm not quite sure how to frame this, so kind of forgive me in advance, but we've seen this year the withdrawal of deficit support funding from Devon, and we've seen Cornwall as a balanced system receiving incentive funding. Yeah. I think one of the risks here then to Cornwall, looking ahead, is as the two systems become one system, what does that mean in terms of the new system's ability to secure or lose incentive funding if that was to continue? And given the scale of the Devon financial challenge, that feels like a particular risk to Cornwall and the Isles of Scilly colleagues. Now, it might be we can't resolve that, but I think there's also that sort of context about how do we work collectively, but also how do we ensure that parts of our new system in 12 months' time are not disadvantaged under the NHS operating regime as a result of some of the deep-seated challenges in
what you're
one part of the system.
unpacking is exactly why this is fit for now, and we need to come back again when we're considering 27, 28. Happy to move on? Is it really quick?
I mean, I think Steve makes a very fair point. We can't change the way that currently the NHS, well, we can influence it, absolutely, but we can't change those rules, Steve. So under the current rules, when we're merged in 27, that is a risk. There's no doubt about that. The way I think that Simon and I and the team want to address that is fundamentally stop us going into an exit run rate in 27, 28 that breaches our financial target with the region, because that then affects everybody. So in this system, we might have people that are in surplus and we might have people that are in deficit. Do you see what I mean? I mean, actually, all systems that aggregate have always got that tension, haven't they, I think? What we've got to make sure overall is we deliver our promises.
Yes, exactly that.
Does that make sense, Steve? Yeah, and I think, Cornwall colleagues, I think, are going to have to be, we're going to have to get this balance so that Cornwall don't feel as though all the emphasis is going on Devon. But equally, if we don't resolve the sustainability of Devon with robust plans, we will spend all of our time just focusing on looking outwards and accounting to people above us for failure. We won't get the space to do the things we need to do to sustain that 27, 28 run rate.
Yeah, right.
Does that help?
Yeah, and if there's anything further that Cornwall and Isles of Scilly partners can do in supporting that, it's in everyone's interest to progress the outcomes you described.
Right.
Am I correct in believing that because Cornwall got their act together, and aligned their whole system, that they had 100 million of debt written off or not. Because
so what
if it was...
I can tell you why.
That's quite a significant issue. Devon it hasn't got its act together. We've got lots of alignment to do, but that fundamentally would put us in a fairly similar position.
So the deal was with the national team, through the regional team, was after 3 years of system break-even in Cornwall, Isles of Scilly, then we would have a £114 million debt written off. And the first 3 years of the ICB, we managed to have 3 financial years as a system in the NHS at break-even, and thus we got the £114 million. So that's what happened. Okay, what else would you like to...
It is worth noting, sorry John, to interrupt, that we've got the 2-year equivalent for Devon. So we have to balance as an ICB this year and next year. And there's ambiguity between that and a system control tool, but at the moment they're focusing on the system convener, which is the ICB, has to balance. And once it balances the end of 26/7, that historical debt gets written off, and it's 300 or so million, so it's worth driving that through.
Happy?
Very happy, but I think we've got to realise that the equivalent in terms of population size would be 200 million written off for Devon if you got it its act together.
So Simon, could you, after the board meeting, just drop a note to the board about the timings and the importance of that? Because if ever you wanted a coalition of the willing rallying behind you, getting to the right answer, it's that right-off moment. Anything else?
And the final section of the paper talks to the actual articulations of the risks, proposed risks for 26-27, and we've moved into that section. So it's just if anybody has any other comments that they want to raise in that section.
No. Any other comments? Because I'm going to move to the recommendations. No? Well done. Thank you so much, Philippa. So just to avoid me losing my voice before the end of the day, could I ask you to turn to the page that's got conclusions on it, recommendations, and we'll go through one at a time. Just give you a second to make sure you've got them. Yeah. So the first one is the note. Happy with that? Second one is the note. Happy with that? The third one is the endorse. Happy with that paragraph? The fourth one is the endorse, the risk appetite. Yep. The next one is the further endorse, the BAF risks. The final one is the final note. Okay, and that's so. Just so I'm clear, in terms of the May board meeting, what does that look like?
So that will look like the risks that we've articulated here, with the assurances and controls. So a BAF that will be a single BAF that works for both organisations.
So after that May board meeting, the committee chairs could be expected then to be clearer on what their agenda items are going to be following the rolling BAF that we'll have. Is that fair?
I think we can get that before then because we've got the risk themes.
Oh, okay.
So we can start having that, and then we can work with the committees.
Really helpful.
Yeah.
Okay. Thank you, colleagues. Let's leave that one there. So let's just see how we're doing. So that's fine. So we've got about another half an hour to go. So we're going to move on to the two IPRs effectively. So I'm going to ask, first of all, Susan, from a Cornwall and Isles of Scilly perspective. Susan, you don't need to present anything. We've taken it all as read. What I would like you to do is there anything that you would like to bring out in a couple of sentences? Because I would rather then allow the board to actually ask you questions, if that's all right.
Yeah, no, that's absolutely fine. I just think the points that's worth talking about is we've listened to the comments the board has made in previous meetings about the IPR and have tried to make it much more forward-looking. We know that the IPR data that we get is always historical data. This one, for example, is for December. So it talks about reaching targets in March and April. And we're pretty much there, aren't we? Let's be honest. So I think there has been an overall deterioration. We have got mitigations around that chair that have been endorsed by NHS England, particularly around UEC. And we know that we've all struggled nationally with some of our planned care performance, particularly in orthopaedics, because of the bone cement shortages. So we are yet to see the full impact of that. I think from a quality perspective, we don't produce, and I think this is maybe something we think about collectively, we don't produce a quality paper in the same way that Devon do. However, we do have quality that goes through the quality balance of performance, and there we give our oversight assurance as per the National Quality Framework Board, in terms of what oversight we are taking for certain of our specialties like stroke, like fractured neck and femur, for example. So that's all within the IPR. I'm very happy to take questions. I'll leave it there.
Very good. Any questions? Frank?
It was just the assurance around the mental health. Looking at it was satisfactory for ICS and ICB, but if you looked at any of the data, it was all red.
So I'm happy to pick that up, Chair. Thanks, Fred. So we are working really hard to reduce our out-of-area placements. As you've probably heard in previous board meetings, we don't have the same mix of specialised or specialist centres within Cornwall and the Isles of Scilly, which means that we do have to use outside of our county. However, we are trying to put in much more commissioned services, both in neighbourhoods as well as within CFT, to prevent that reliance, in the same way we want to do with general healthcare, the reliance on institutional beds where possible. We have got a mental health workshop that we are working collaboratively with CFT coming up in April, that will look at, in terms of what we need to do, some of those pre-commitments for commissioning intentions for next year, but we know that we've got more work to do around out-of-area placements and talking therapies particularly. So it's a well-trodden path where we know where our issues are within mental health. It's bringing not only CFT together, but also other providers. Our VCSE are becoming more and more involved with some of our mental health services, and also how we do that left shift. We always think about left shift from our acute trusted community hospitals. It's also from mental health services into our neighbourhoods.
Thank you. Okay. Could I ask Simon, from the position on the financial position as at month 10, any thoughts that you want to share? Any questions for Simon on the financial position? Good. Continue to be on track in case you didn't heard, which is an important point to make. Yeah. Sorry, did you say for both systems? Can you just...
Yeah, so both systems in terms of the financial position on track. So Cornwall balanced position as per the plan, and for Devon, we're still looking to get to a 60 million or so deficit, but that's not going to change. We're in a fairly assured position now. And just to be clear, that includes the benefit of deficit support, so it would be 92 million if we didn't have deficit support. But we're not expecting that to change as a result of a whole range of factors, but there's been various bits of support from NHS, etc., which has added comfort to our position.
Very good. Okay, thank you. Susan, are you happy therefore for me to summarise the recommendations? Yeah?
Very happy. Thank you.
Okay, to acknowledge, I think we're acknowledging, and we've certainly discussed the issues in the main report. We've just had from Simon noting the financial position and the forecast at month 10, and we'll just capture that for Devon and for Cornwall, if that's all right. I wasn't quite sure what you wanted on the assurance statement. What is it that you're after on the assurance statement, Susan?
I mean, this will be...
Just noting it, is that what we're saying?
Yeah, I think it's just to acknowledge it. We've got a deterioration, Chair, that we are working with, particularly around UEC.
Okay.
And the assurance around those plans.
Okay, so we're just noting that. Everybody happy with that? Lovely. Thank you very much, Susan. Well done. So let's move on to Libby, and the same thing for Devon, please.
Lovely. Thank you, Chair. So take the report as read. Simon's already covered off the financial position for Devon, so I'll just pick out a few key messages around performance, quality and workforce. So we have three particular areas of concern where we're behind plan: 4-hour ED performance for children, mental health ED breaches and NCTR. but we do have recovery plans in place for all of those areas, but unlikely now to see full recovery in year. For our ED performance for children, we did see a slight improvement in this report at 77.2 in month 10, which was up from 75.9 in month 9. But just to note that that is against the 95% target. But we obviously have confirmed that that target wouldn't be achieved in this plan. We've continuing to see a rise in mental health ED breaches, but we do have a joint plan between DPT, Live Well and the ICB to improve this position, and that will go forward into our plans for 26-27. So these remain areas of key focus for us. From a quality perspective, obviously our primary quality risks are related and correlate to those specific areas of performance that I've made reference to. But it's also worth highlighting the continued strain on our children's services and SEND. And these are key areas that, as you heard earlier, in terms of the commissioning plan, that we are driving forward in terms of longer term resolutions. Also wanted to just note a couple of areas of good performance in terms of quality. So leader timelines, 69% have been completed within 6 months, which puts the ICB amongst the best performers nationally. And for vaccination uptake, flu, we're at 62%, which is 7th nationally, and COVID at 67%, which is 5th nationally. For workforce, continues to be a challenge in delivering the workforce plan, at month 10 being 816 above plan. But again, this is active work that's part of the development of both the 26-27 and medium-term plan, in terms of strengthening those workforce plans for the coming year and beyond. Just of note in terms of the ICB's annual plan, just 2 key areas to mention are around the delivery of both the Pharmacy First and the Maternity Transformation Programme, both which are on track to deliver on our key priorities for us going into 26-27. Thank you, Chair.
Lovely, thank you. Can I just ask, Anne-Marie in her briefing earlier on talked about the SEND and children and young people stuff, Libby. You mentioned it in there as well. Can I just be clear on how we intend to work with each of the councils to actually get to a position that hopefully is positive in that? Yeah. Yes, I want both of you to come in.
Yeah. So certainly reporting it within the local authority, as concerns. Yeah. However, we do have, I can absolutely speak from a Torbay perspective, and we had our DFE stock take earlier this week, and we were able to set out to them that actually we do now have detailed plans which are starting to bear fruit in terms of reducing those timescales. However, we do need to go further. But certainly from a Torbay perspective, and I'm sure that's replicated both within Devon County and Plymouth, working with, from a Torbay perspective, particularly Sue Smart and Penny, in terms of the focus, and Sue's on the screen. I didn't, because I went out to the ladies. I didn't see you join Sue. Hello, Sue.
Yep. So I was just going to say, obviously Sue's joined because Penny isn't with us at the moment. Penny Smith, our CNO. So I'm sure Sue is far closer to the detail of this than I am, Chair, at this stage.
So welcome, Sue, to the board. The exam question is maybe slightly different to the one you expected. So what we're looking for is just to get your sense on SEND and children and young people and how we're going to work as the ICB with each of the councils in Devon to make sure we resolve the issues that are there.
Yeah, so thank you, Chair, for that question. We've got some really effective partnership working in place, as Anne-Marie outlined, and that is replicated in the Plymouth and DCT footprints as well. We've worked in partnership on the improvement plans, and we're currently undertaking the maturity assessments required for the SEND reforms and jointly working up the SEND reform plans. There are some joint arrangements in place, as we have in Torbay, which are very constructive in helping us to move that improvement forward together. And we're absolutely seeing that improvement that Anne-Marie indicated in in terms of early improvement in Torbay, but absolutely improvement in the Plymouth area that's been recognised by the regulators in the recent monitoring visit that they completed.
I'm just wondering, Mark, it's all right with you and Libby, whether Philippa might actually want to send the key elements of Anne-Marie's report relating to the children and young people in the SEND so that we can actually make sure it's covered off. The questions that came out from Anne-Marie. Because I'm hearing pretty positive stuff from Sue, and I'm not quite sure from Anne-Marie's report I got quite such positive statements. I'm just trying to reconcile a very positive statement with quite a difficult challenge.
So the report that I submitted was prepared by the DCSs, so the Directors of Children's Services across all authorities. Correct. So they have been long-standing concerns. Right. So if I take us back to our SEND inspection last year, when we sat in the room and Steve Moore was in the room with me when the inspectors are saying to us, it's a 2.5-year wait for a speech language assessment. There were multiple examples, and that is replicated. Has been replicated across. We are seeing improvements in that. They are nowhere near where they need to be. That is the issue. Okay. So absolutely, we are working together, but we are not where we need to be for our young people.
Okay, that's good to hear. So you want to come back on that?
Yeah, so just to clarify, so I think I haven't seen the content of Anne-Marie's report, but from what I'm picking up in this conversation, I would agree that we've been making improvement with the structure and the capacity that we've had in place. I expect what the local authorities may be raising is risk to that, given the changing nature of the ICB at the moment.
Okay, well, take a look at it afterwards and then feed into the team your professional insights. Steve?
Thank you.
Yeah, mine was a separate question, if it's okay. It's just about the financial position. So if I could ask a question and then possibly a follow-up, depending on the answer. So the report says that the system deficit's forecast to be 64.4 million, and that includes the loss of 15.4 million deficit support funding for Torbay and South Devon and the loss of 11.5 million deficit support funding for UHP. Yeah. And I'm not sure I quite understood what Simon was saying, so could I just ask, is that correct?
That is correct. So the plan started off the year that
yeah.
there was a requirement to deliver a 56 million
yeah.
net deficit position after deficit support. Also, I'm doing this thing. Yeah, after deficit support. So the deficit support, 50% of that has been continue to be provided because for the first 2 quarters people hit their position, all organisations, and half of it was lost in the second half of the year, so that the overall deterioration was 34 or so million through the RCHT movement in the position which we'd be familiar with, plus the loss of about 26 million.
Okay. You don't mean RCHT, just to be helpful.
No, RDUH. Sorry. Steve, no wonder I'm sitting over here.
I saw the glazed RDUH. I don't think so.
Sam would be pleased with that remark. But anyway, so that's the position. So we lost half of it, and that's why it's not quite as easy to understand.
Yes, that's very helpful. So supplementary question is about cash then, because if I'm looking at that, RDUH 44 million adverse position, and then Torbay losing 15 million that they would otherwise have expected to, and UHP 11. Can we just have assurance that there isn't a cash risk in any of those organisations, please?
We can. At the same time, the change in position at RDUH was signed off nationally. They submitted a cash support plan, so the additional cash was brought into the system, and also we had to demonstrate that amongst our organisations we could support the remaining challenge. So the cash is manageable for this year.
Thank you.
Did you want to talk about any extra support from the 1st of April you're getting for Devon or not?
No, right. Not currently.
Okay, so let's just ask, are there any other questions on this before I move to the recommendations? No? So I think we can note the continued unfortunate deterioration. Yeah.
Sorry, can I just add only one point, and it's just because of the relationship between this year and next year. So I just want to state the obvious. So there's a huge programme of work pushing for improved CIP into 26/7, and that is underlined by one of the big issues this year has been lack of recurrent CIP delivery and lack of CIP delivery. So it just underlines the fact the work of the next 3 or 4 weeks is absolutely key. We can't be in that position starting from the 1st of April. So just to make that point, thank you.
Okay, so we're going to note the continued deterioration. Are you happy to approve the key recommendations and actions identified in the report for each of those areas? I assume you are. Shout me down.
Yeah, John. I think just on the SEND stuff, we need to. What we need to do is engage with the partners and look at what further we could do to actually help the partners with that and the patients, more importantly. So I think that's something with Susan's new role from 1st of April. I'll be looking for Susan and the colleague up on the screen who's got to help us with in terms of bringing that to fruition, and we'll take that through the executives.
Thank you. Anne-Marie?
So it was just to make the point that absolutely the executive to executive, reset, Mark, that we talked about earlier will absolutely help us do that. But let's not forget that SEND is a local area partnership. It's not the local authority's responsibility. It's a joint responsibility.
Yes.
Correct. Yeah, correct.
100% correct. Yes. See.
Apologies, John. I appreciate I'm just not cited on this detail, but I guess just looking for an understanding as to why the finance position is limited assurance,
as opposed to
something worse.
Okay.
Because I think we're worried about the exit run rate into 26-27.
Yeah, and I think
I'm not advocating it should be anything higher, Mark. I'm just
unassured. We had a
you're unassured, right?
I don't know. I don't know how to.
What you will have missed is that when we started as a cluster, there were unfortunately quite a lot of papers that came to the board and committee that actually talked about limited assurance, that the committees, the non-execs, downgraded to unassured. So that's the history of this, and it was on a regular basis. So that's what you're teasing out here. I think one of the questions we can assure ourselves of, Steve, is that now we've moved to the 92 million number, and given the fact that we're a week away from effectively ending the year, there should be really enough assurance within the limited assurance to not have to worry about downgrading it. But Graham,
assurance
you're happy with that?
Yeah, sorry.
Yeah, just to be clear, because this is coming back to some of my earlier points, the ICB is actually ahead. It's making a surplus of 8 million. So actually it has been and continues to be and will be ahead of its budget. The system had a reset at month 9 with an approved forecast. So it is only limited in terms of hitting the new forecast pulled down by the other domains within it. So it's against the new target, not the original.
Yeah. And again, just Mark, for a bit of bringing you up to speed stuff. In the early days, nomenclature got in the way because a lot of, I came from the Cornwall side. The ICB only ever thought about the total system. It didn't ever think about its own ICB position, whereas there was a lot of ICB is just the smaller bit in Devon, as opposed to thinking about the total element of it. So that's why there was an element of limited assurance, yes or no, depending on whether it was the smaller bit of the ICB or the total system bit.
Oh, I see.
Okay. Made more complicated by the financial year from the 1st of April, of course, removes our control total as an ICB. So there we go. Okay. Happy with how I captured everything else to your satisfaction? Very good. Okay, so where are we in terms of the next item? I think we're done. I'm going to turn to the members of public and notice there aren't any. None on the screen, I don't think. Is there any other business anyone would like to write while we're in the public session? Okay, in which case I'm going to close. Thank you very much. I'm going to close the public session at 15:15.